Oh, cool. Yeah. Okay. Yeah. So what?
Great, welcome everyone. We are going to get started and we have a lot to cover today. Are we recording? Good morning, everyone. Welcome to the May meeting of the Universal Health Plan Governance Board. Let's get started with the roll call.
Helen Belenka,
Here.
John Wayne Cheat,
Yes.
Amy Phillips. Here. Michelle Glass,
Here.
Bruce Goldberg is on leave, Judy Richardson. Here. Cheryl Ramirez. Here. Mary Lou Henrich. Here. Mike Leahy.
Present.
Thank you, everyone.
Great. Quick agenda review today. The meetings seem to get more and more packed as we get farther along. This is going to be a very busy one. Before we get started, I'm going to ask all the board members to really pay close attention to the time allotted for each of our agenda items. We are going to have a hard stop at 10:30 for a break because we have a lot to cover in the portion of the meeting that happens after the break. So I'll ask all of your cooperation with that so we can stay on time and get to the decisions we need to make. After our executive director's report, we're going to have a report out from our community engagement and communications team. Then we're going to spend the rest of the early part of the meeting talking about administrative savings. We have a guest speaker today, Dr. Shao, who's going to be talking to us, and we'll have a board discussion after his talk. And then after our break, we need to get to our revenue strategies. So Echo Northwest will be here to give a presentation on their report and some other information. And then we need to vote on some elements of the basic revenue strategy as well as the overall revenue strategy itself. And then Lee is going to be giving us an overview of how our report is going to be shaping up because we need to start looking at some drafts of that. So it's a packed meeting. And then before we get to public comment, we have just two items on our consent agenda. It is the minutes from our April regular board meeting and then our special meeting that was May 12th. There are two sets of minutes there. Those are the only things on the consent agenda. Again, you can pull them off the consent agenda if you'd like to discuss, but is there a motion to approve those minutes?
So moved.
There's a second. Second. Great. Any discussion? Okay, let's do a roll call vote.
Helen Belenka,
Yes?
John Wayne Cheat,
Yes.
Amy Phillips. Yes. Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thank you, everyone.
Excellent. So in terms of public comment this month, we heard from quite a number of people. Melanie Bobbitt wrote in with concerns that the taxes in the UHP are too high and recommends that there is an adjustment for families with children and that people below 200% of federal poverty level also are included in the taxes. Stephanie Santos wrote to encourage us to consider the needs of patients who need routine infusions for their medical care. Nicole Minkoff and Sarita Trawick wrote with concerns about how behavioral health will be integrated into primary care and how it will be reimbursed. Heidi Pendergrass and 41 others wrote to request that that psilocybin therapy be covered in the UHP. Kel Fox wrote requesting that we consider taxing wealth instead of labor with capital gains and estate taxes, which proportionally affect wealthier households. Catherine Kirkham, Ann Waters, Melissa Gouger, Samantha Schurer, Christy Levac wrote with general support for a universal health plan. Rachel Christoph is a remote worker whose employer is in Connecticut, and she had questions about retaining coverage through her employer. Zachary Krebs, Mary Fraser Smith, Sarah Levac, Brody Welch wrote advocating for acupuncture treatment and coverage in the universal health plan. Linda Krieger wrote with some detailed information regarding our revenue strategy, and I'm going to reserve her comments for when we get to that portion of our discussion. She had some really thoughtful things to say. Lou Sinninger had some concerns, questions, and complaints about the Artemis report. John Santa and Mike Huntington wrote to encourage us to think about including more administrative savings in the UHP because it will operate differently than current insurance plans. Warren George wrote in with comments about the transition committee discussion and points out that there's significant variation in the estimates of administrative savings, warranting more study before committing to a number. He also points out that Oregon's rate of Medicare reimbursement is low compared to other states, including California, which may be worth considering. That's all of the written public comments. And then we have only one topic on our agenda, which is a voting topic. It's our revenue strategy. There will be several votes in that agenda item on certain elements of the revenue strategy and then the revenue strategy as a whole. But I believe we have one person signed up for public comment on our voting strategy, and it is Lou Singer. Lou, are you ready?
Yes. So I don't want to take up too much time. My main concern is, you know, our how do we finance it? And so far, I think what you're going to talk about is the idea that people with more kids or those with families will pay more on this item. And I find that as an antithesis of universal health care, because it's based on a market model, which says that if you use more care, then you have to pay more. So, you know, those with long standing conditions that cost more, like cancer or other long-lasting chronic situations, are going to pay more. That's the principle that you're talking about. And I just want to say I think that's going down the wrong road. I think universal care is universal care. And what we pay and everything should be established on the taxes that everybody pays. So that's all I have to say. Thank you for listening.
Lou. All right, now we can move to the executive director's report. I'll hand it over to Mimi.
All right, thank you. So good morning, everyone. I'm Dr. Mimi McDonald, the Executive Director of the Universal Health Plan Governance Board. I'm going to give a couple of updates. First off, talking about board outreach. The HCAO town halls finished up in April. I'm incredibly grateful for our board members who presented at them, were present for them, for the work that HCAO did, and for all the people who showed up. We also have a couple of our board members are going to be at the HCAO conference, which is on May 30th. I'll be there as well. I also had the opportunity to present at the ONA conference on May 5th, and that was really a great opportunity. Grateful for that. Couple other things. Our website, excuse me, continues to be updated, which is exciting. So just chipping away at things, trying to make it more, some things more accessible, or removing some sort of outdated materials off the website. So that's going to keep happening. For those of you who aren't here, you may not notice, but we are in a different room. We're in the building. So I put the in-person meeting site challenges. So just like to apologize to our board members and our people who come to us. We've been bumped a little bit from our regular meeting space. We still have a little bit of a challenge TBD. We do know that DCBS is going to remain in this building. They're not actually moving from the building in 2026. So I'll just tell people to stay tuned. We hope we'll either be back up in our big room or at least get to stay in this room. So thank you all for your flexibility. I appreciate that. Next up, and I just want to spend a couple of minutes talking about this. So kind of 2 points around communications and also public meeting law reminders. So the first point has to do with our communication policy, and these are included in all the, I know there was a lot of things included in this meeting packet. It was definitely crammed full, but In November of 2025, the board approved an addendum to our general policies and procedures, especially under section 16, trying to clarify what it means to speak for the board. And so kind of the main thing I just want to remind folks, now, obviously, people presented at the town halls and board members certainly can discuss the Universal Health Plan Governance Board. However, unless they're expressly authorized by the board, no board member has the authority to speak on behalf of the board. So please try and remember that we have, a set slide deck that we supply people with, and that it's really important, especially in the upcoming months, that as a board, people speak as a unit. And as tempting, and I confess sometimes I fall into this trap, do a little bit of conjecture, but as tempting as it can be to really talk about decisions that the board has made, try not to expound on or potential decisions that may come up, ways that things may go. So that's just one thing. So thank you for that. And I was asked to speak about that. Now, the other thing, this is also really important, and this has to do with public meeting law and communications between board members and between committee members. So I've included, actually, this was something that was created by my predecessor. It's a sheet that says communication best practices. And I think people are very well aware of the public meeting laws. It says, well, if you send emails and if it's a quorum of people, or even if it's sequential, that breaks public meeting law. And that is absolutely true. But we also want to avoid sort of the essence of that, which is deliberating amongst either board members or committee members outside of the public meeting venue. So it's really important. So if there is factual information, studies, etc., to be sent out, that is not a problem. It is best practice to BCC people, because then you can't reply all. So that is very important. And also, and so this pertains to, if it's that you really want to make sure that you are doing the factual information, and please refrain from seeking or sharing opinions that might be considered deliberations. So we don't want to send out emails asking questions, because then people understandably respond to them and deliberate. So I realize we've gone over this before, but I just, members of the public have voiced their concern over this issue. And so it's really important that we all work towards that and really have all of the deliberation occur during the meetings. It doesn't mean we can't share materials, and of course things will always be posted, but I just want to make that clear. So I don't know if there's any questions or anything else anyone wanted to chime in. Okay, great. Thank you very much. Next, we'll pop onto the budget. Very briefly, we still have money, yay, about $52,000 till the end of the biennium. So that's nothing new. So I just like to keep us updated every month. Next slide, please. And then this is our consultant budget. So people, I think, are very well aware that our Milliman consultants, we have spent on their entire budget. People may not be as aware that our consultant from Wentz Jackson, Patty Wentz, she essentially has no more remaining budget. So and her budget has already been increased once to the amount that it was available. So it is with sadness, but as Patty says, all contracts end. So we are so grateful for the work that she did. We miss her. Artemis, you can see there's a little bit of her budget remaining. We actually are very grateful. Diana, we have one more meeting coming up with members of the deaf and hard of hearing community. So that's very exciting. That will be the final focus group meeting, excuse me. And then you can see the rest. We do still have some funds with Echo Northwest. Again, this is through April. And then you can see our translation and interpretation budgets. Down at the bottom is Bridges, Oregon, and that is a CBO that is a disability-led organization that will be helping us facilitate that focus group. So we're incredibly grateful and excited to have them on board. And next slide, please. Just as a reminder, people are probably aware, again, that we will have 2 open board positions. Michelle Glass, after extending her service, will be leaving after September 2026, and Amy Fellows will be, her term finishes up in December of 2026. So we'll have a new person coming on, we, at this point. So the applications are evergreen. There are links on how to apply. I've also attached a link to the board member handbook. The deadlines for September Senate confirmation, I have them there so people are clear. Applications must be received by June 22nd, and we are going to look at applicants for both positions. We want to be able to choose applicants for both positions, so we don't have to go through this again. So for the one that's going to be open in October, be filled in October, and the one that's going to be filled in January of next year, applications must be received June 22nd. Tell your friends. Remember, please, a reminder that these are the community engagement positions, both of them. So these are people who have expertise in that field. And then there will be a board work group. We already have 2 members who are actually our board members who will have volunteered to be on this. Those are board members who will be rotating off of the board, are going to be part of it. And I'll turn it over to Chair Belanca to add some more comments about how that process works.
Yeah, thanks. So as a reminder, the governor's office selects all board members. So, but this board has an opportunity to submit recommendations to her office, and then ultimately it's the governor who makes the choice. And in the past, how we've done this is have a small work group. I'll remind the board that when it's just a group of only board members and no community members, we call that a work group instead of a committee. We don't need to vote on that. It's just a small group. We've done it several times. We've had a small work group of board members who get together to just go through all of the applicants and put together a list of candidates and compare notes and then decide on a list to submit to the governor's office. As Mimi said, both Michelle and Amy have already volunteered to be on that work group, which we're grateful for. I'll be on that work group. Probably 3 people is enough, but if anybody else is interested in being on that work group, make yourself known now, and you'd be welcome to join us. Mary Lou? Okay, Mary Lou wants to be on it.
Do we have to cut it off there though?
Okay, yeah.
Because we can't have 5.
Yeah, because we can't have 5. Yeah.
I just want to say, because we were not doing a public meeting thing. Thank you.
Yeah.
Okay. And I think with having finished all of that, thank you so much. And I get to turn it over, I believe.
I was just gonna ask one question
Oh,
on the
please,
last
yes.
slide. So I think in the past, at one of the times that we were recruiting new board members, that it was on the DCBS like social media and things.
Oh,
so
we
it's
can ask,
just
yeah,
there.
we can ask to post that.
Or
Yeah,
yeah, and like or something that's like that we can share around.
Yes, yes.
Yeah, that'd be good.
Okay, yeah, absolutely.
That's right, we had and we put all posted on our like
LinkedIn.
LinkedIn.
Public
Yeah.
stuff.
Yeah.
Thank you.
Yeah,
we'll
thank
put
you.
that. I appreciate that. Thank you.
Okay, my turn.
See, so I'm gonna miss you so much.
Yes, so now we'll move on to communications.
So, yeah, so as Mimi mentioned, in April, board members participated in the 9 Healthcare for All Oregon town halls throughout the state. We held a special board meeting on May 12th to go over the focus group report covering the 12 different groups that were facilitated by Diana Bianco of Artemis and Consulting and Mimi McDonald, RED. As Mimi mentioned, we are going to have one more focus group with deaf and hard of hearing community that Bridges Oregon is helping us coordinate. And kind of from that process, I think they had sent stuff out kind of a little bit wider to disability community. And the executive director of Autism Society Oregon is interested in learning more. So I'm gonna be having a conversation with her in June and then just see if we have to cut off the focus group part to get her work moving forward, but that if they want an info session or something, then I would do that. So our next community engagement and communications committee meeting is on May 27th. We'll be sharing the focus group report with them, as well as Colin Stackhouse from HCAO will be presenting the town hall survey and the data that was collected from the attendees of the town halls. And that's something that we can also share back here with the board. We also want to direct the board and public to the documented community engagement and communications committee public comment from our April meeting. That was part of our documents. And so since we now have added that 5 to 6 p.m. time for public comment at the community engagement and communications committee, we'll be doing that as a practice, kind of Michelle and I kind of doing a wrap up of combined written and oral and putting that forward for the next board meeting. Did I miss anything, Michelle?
Looks like Mike has a question.
Yeah. So I'm really grateful to you and Michelle for doing this stuff. I've learned a lot from this process. I'm noting though, between our last board meeting and now, some major disruptive things have happened. We've had an election where the taxes have been overwhelmingly essentially defeated for roads. Providence Health Plan is in the process of doing implosion or something. And I don't know how they're going to be taken over by a for-profit or whatever happens. And the third is there's been some federal publishing of final Medicaid regulations that are very complicated, 192-page document that I fell asleep with last night. So I guess my own sense is that I think as we're thinking about our future, I think we need some additional communication capabilities regarding finance, and or I think it's unlikely anyone will ever pass a plan in our current form. So that's my comment.
Yes, thank you. Noted, and also our budget situation, I don't know what we're doing.
Right.
Well, as a reminder, as part of our
Next
POP,
slide.
the policy option package for 25-7-29, a huge portion of that
Is
is
engagement.
engagement and talking about how do we talk about this plan? How do we get people on board with it? How do we build a coalition of support for it? So that is a huge body of work. You're right, Mike and Amy, like it's a huge body of work that we need to take on, but
And also what we need to put into our report about the importance of that.
oh, absolutely. Yes, absolutely. You're right. So we'll be talking about our report later in the meeting. So let's tend to that piece in there.
Thanks, Mike.
Great. Anything else? Community engagements and communications? No? Great. Thank you. So far, so good. We're on time. Okay. So now we have the great pleasure of welcoming a guest speaker. Dr. William Shao is the K.T. Lee Professor of Economics Emeritus at the Harvard T.H. Chan School of Public Health. He earned his PhD in economics from Harvard University and is also a fully qualified actuary with extensive expertise in both private and social health insurance systems. He served as the Deputy Chief Actuary for Medicare and Medicaid. And in recent years, Dr. Shao has become a leading global expert on single-payer health systems. He has very graciously agreed to come and speak to the board about potential administrative savings. And we're so happy to have you here, Dr. Shao. Thank you so much.
Well, thank you for inviting me. It's an honor to speak before the governance board. And next slide, please. Your board has a very important mission to really carry out, I call, a system reform, because a UHP plan is a type of a single payer plan, and from the worldwide experience, we know you can achieve three things through a UHP plan. And one is universal coverage with equal reasonably benefit packages for everyone. And that you already know that. The second part is improve access and quality of healthcare for all the people. Again, your board, I'm sure, knows that. The third part is reduce administrative costs and improve the efficiency of the health systems when the system is under a so-called market arrangement, and cut waste in a great deal of in the healthcare system. And that's the part I'm going to focus on today. And next slide, please. I'd like to present really 5 major savings you may receive. And this is based on what I learned when in 1977 under President Carter, I was engaged to actually estimate the cost of the national health insurance President Carter want asked Secretary Cassiano to design. And I had to actually study then what would such a national health insurance, which is a UHP, could do. And I discovered studying other countries in the world, what savings you can produce. And this is what I'm going to summarize for you. The first one is reduce the provider's billing and insurance-related administrative expenses. I'm sure that you board members already are familiar with this. This is called the BIR briefly. To back up how the savings can be produced, let me just ask you to think about why in the United States, when you go to a physician clinic or hospital, the first question they ask you is, what health insurance do you have? Or which plan is it? That is because for any provider, and I did this myself personally, for example, a solo physician practice in America, physicians, patients are covered by, on average, 8 to 10 different health insurance plans. And each insurance plan has different benefit packages. So a practitioner has to deal with 30 variations of what's covered by insurance, what advance authorization he needs for tests, for hospitalization, and how much he will be reimbursed. This takes up tremendous amount of time and expense costs. Let me just explain my personal findings. I found on average, a physician had to spend 8 to 10 hours each week of his busy week to deal with insurance billing and the reimbursements and the variation in the insurance that he or her patients had. And second is 25% of nurses' time have to deal with it. And third is he or she has to employ at least one full-time administrative assistant to handle the claim filing. And I will, in a later slide, I will quantify that for you, how much of the health spending in the United States is being spent in this BIR cost alone. Under UHC, you can vastly reduce that. And the question is, do you want to account for that? That's your board is faced with. Second is item savings is right now in in United States, and I have not done a study in Oregon. On average, for large employer insurance plans, 10% of that premium goes for insurance companies' administrative expenses, but about half of that goes for sales, marketing, and commissions to the agents. And then the overhead of the executives of the insurance companies and underwriting costs. That under a UHC, a single payer plan, that can be drastically reduced. Again, in a later slide, I will quantify for you based on dozens and dozens of empirical studies, not only in the United States. United States, one that's studied most is Kaiser plan. How much can they save on that? And the Geisinger Intermountain plans are also being studied, and they all come up with the same findings. The third item I want to alert you is the savings from fraud and claim abuses. FBI 10 years ago made a public statement. Fraud in medical care accounts for 3 to 10% of the healthcare costs. Most of the FBI investigations do not result in prosecution. It's because the legal expenses for the government is so high. They do not actually prosecute most of the cases. They discover under Medicare, 10% of the doctors, this is under Medicare, will bill patients for working for up to 100 hours per week in patient care. And when you combine with the private insurance, you can imagine how many doctors and the hospital may be overbilling. This is a fraud which FBI is talking about. But then there's more than that. United States is famous for its coding of hospital services and physician services. The codes get expanded because providers want to expand the code so they can add some little thing and they can upcode and get a higher payment. Let me give you concrete data. When the DRG was established, there were only 478 categories. Hospitals were able to push the United States to expand it to 1,000. For physicians' billing code, it started out with only 2,000 to 3,000. Now the physician's billing code is 10,000 codes. Providers choose to do a little bit more things or classify even the patient's age differently. They can get a higher coding and get higher pay. Under UHC, if you have a good administrative system, you can remove most of that. That's what the other countries have done. And the fourth item is under UHP, I'm sorry. You would establish a uniform clinical record system. Hopefully, you will also combine that with a claim information system. In countries with UHP, they develop a unified clinical and claim payment information system that reduces the duplication. And let me give you an example of Taiwan. You go to any doctor's office, the doctor just clicks on the information system. He or she can, with your permission, can see your whole medical history and know what test results, what scans you have had. When was your last visit? Or what specialists you have seen? This removes tremendous amount of duplication of services and tests. Particularly nowadays, the MRI and CT scans are used so frequently. Every different provider in America say, I have to do my own test because I don't know your whole record. Again, this is the amount of savings has been documented by the America's unified providers with a unified clinical record like Kaiser or Geisinger or Intermountain. And I will quantify how much savings they have obtained. And let me tell you, there are dozens and dozens of academic publications evaluate these savings, published by referee journals, top journals. So I'm not giving you just my personal observations. Let me make clear. The last item of savings under UHP is if you decide the administrative agency say, okay, now we're going to bargain for bulk purchasing the pharmaceuticals and bargain with the pharmaceutical companies and its intermediaries. As you know, the price paid in America today is 2 to 3 times of what Canadians are paying for exactly the same drug, including brand drugs. Same thing is true, United States is paying 2 to 3 times of the European countries what they're paying. It's up to your governance board. Do you want to do something about this? Now, let me, next slide. Let me just elaborate with what I just said to an additional consideration. For a provider under UHP, they are going to reduce their bad debts because everyone will be covered and covered fully, quite comprehensively, under your proposal that task force has developed. Second, physicians are going to gain 6 to 8 hours of saved that many hours each week for patient care now, rather than dealing with the insurance matters and reimbursement matters. Then there's another item if you can this require your action or that you can actually introduce statewide, let's say, health expenditure control act like Maryland's global health, global hospital payment system. Over 2 years, it's documented and published data. Maryland saves 3.6% of hospital costs. This is what you can do to save Oregon citizen residents money through UHC. Next slide. So now I just want to actually quickly say what I just told you describing it. There are really a lot of evidence on the billing and the insurance related expenses. Your executive director, Marion McDonald, already presented to your transition committee this past week. And I'm just copying her slides, show you marked in red. For physicians and hospital, just change to a UHC system, you can reduce by 10% of the healthcare costs. That item alone. Next slide. Then I tell you about the fraud and claim filing abuses. And I already gave you some of the data, and I just repeat. Besides FBI's pronouncement of fraud, which actually we have documented, actually empirically is documented in the lawsuits filed. The other part on upcoding, academics has found there's at least a 5% up to 10% of upcoding and abuses in filing claims, which UHP can actually vastly reduce because you will have one single claim filing information system released. Next slide, please. Then the duplication, reducing duplication and unnecessary healthcare, that will improve quality because this will produce a coordination of health services and also reduce the overuse of drugs because physicians often do not know what drugs the patients are taking fully. They prescribe new drugs, produce toxicity. If you look at the hospital admission rates, high percentage of hospital admission rates is due to toxicity from drug usage. So you can improve quality and reduce costs, but that requires your UHP to produce a unified clinical record for all clinicians. Okay, go to my next slide, please. Sorry, I'm running out of the time. I'm going to, I want to then, I explain how the savings can be produced. Now, how much does the saving? There's a common agreement. The savings from billing and insurance can save United States at least 10%. So I just put down 10%. The Milliman report also agree with this figure. They cite it. But in their report, they assume this money is going to be given the providers, not go to your Oregon people. 100% of that's good, because they could say, we're going to pay them the same now, although their costs going to reduce, we're going to pay them the same level. It's up to this board what you want to recommend who should receive this benefits. Milliman reports assumes roughly your administrative costs for insurance will cost 7% of the expenditure benefit costs. That, in my view, is too high. Medicare only costs 1.5% of its health expenditures for administering Medicare. Medicare is a uniform health plan for the elderly in America. Other countries doing that, like Taiwan, spend less than 2% for administration. You can save at least 5% with a UHP, Unified Administration. The question is, who do you give this to? I will raise that issue a little bit later. Fraud and claim, I'm not claiming the 10%. I'm only feel the legal procedures and so forth. But most of us who work in this field believe you can save at least 6% or 8%, up to 8% of the health expenditure costs. Duplication of visits, tests, scans, hospital admissions, and so forth. Drug toxicity is 8 to 10%. Pharmaceutical prices, that depends how much you're going to bargain with pharmaceuticals. If you can reduce the price, we're paying 2 to 3 times. If you just reduce that by a third, you will save 5% at least, because 15% of our health expenditures today is spent on drugs, inpatient as well as outpatient. If you try to bargain down to only half of what we're paying, then you will save 8%. So I'm giving you this range. So if you add this up, in America, without new information system, you can reduce the billing, insurance, related expenses, and fraud, and insurance probably could be 20 to 25%. If you introduce unified clinical claim information system, you can save another 10%. This is the magnitude your board is faced with. Next slide, please. Let me just summarize that. Undoubtedly, there's not one doubt in my mind, or most experts' in mind, there will be significant savings, administrative savings, reduction in fraud, and so forth, in establishing a UHP kind of program, which is a type of single-payer system. My second observation is Milliman report did not give any of that savings to the citizens of Oregon. They acknowledge the BIR savings, but they say, oh, we're going to continue to pay the provider the same amount. That de facto says we're going to give that savings to all the providers. To me, it's up to this governing board who should receive that savings. Then I also mentioned you can introduce a unified clinical claim record system and so forth. You can have additional savings. But then my fourth slide says have a WHO. Your board have to decide who is going to benefit from the savings. Some of it must go to the people. Some of them may go to the provider. But right now, the Milliman report is all giving, they only acknowledge 1 out of 5 items, and they gave all that money to the providers. So your board has an important job to do to say who is going to get these savings. Then Milliman report went through, by the way, it's a very thorough report, but the actuarial method, I'm a fully qualified actuary, but the methodology and considerations based on private insurance. Milliman Consulting actuaries are really a top firm. They did a good job for you, but they are not familiar with UHP, which is a system change. So but maybe the task force suggested you create a public agency to administer the UHP. That means you're throwing away all the knowledge, database, computers, programs of what your, let's say, Kaiser in Oregon, or what the Blue Cross Blue Shield of Oregon have already done. Medicare did not do that. Medicare says, I'm going to control the policy and the finances. I'm going to let the operational side, I'm going to contract out to those who already know how to do it, already have programs and process and staff. So what Milliman report gave you is a new public agency, and I hope your board will reconsider that. So my last quick is I recommend you establish a unified clinical and claim information system. Thank you very much for your patience. Listen to me, my rambling, and I'd be happy to answer any questions.
Thank you, Dr. Shao. Do any board members have questions? Go ahead, Chandra.
Thank you very much, Bill, for a very succinct and important commentary. I have a question regarding your last comment about what type of agency is most suitable in administering the universal health plan once it has been passed for all the legislative processes. And more specifically, do you think an organization resembling Taiwan's National Health Insurance Administration might be appropriate, or you envision a very different type?
I'll give you my honest opinion, although I led the team design the Taiwan's UHP system. No. Politics intrudes. Civil service rules intrudes. And when the government is a single agency administered, there's no competition. And consequently, over time, the efficiency of that agency actually stagnates. Its practice gets a little bit outmoded. And also politics intrudes. I think the Medicare type of agency, the policy and the finance responsibility and accountability is in the government. But operationally, it's given through competitive bidding to any agency can do that work well. In Vermont, when I designed the UHP program for Vermont, the government officials want me to make sure the government runs it. I challenge them, say, if you do, why don't you actually see you can compete with a private agency or not? Let's put you on equal footing. If you can do better than private, great, you win. And that's my answer.
Michelle?
Thank you, Chair. And thank you so much for this presentation. I really appreciate you coming in and speaking with us today. My question is how we might calculate the specific savings for Oregon, because I think one of the things the board has been wrestling with is that we're in a unique situation where we're a state within a national system that is our fragmented for-profit system. And so it doesn't totally make sense to me that we could apply all of the assumptions from another entire country where they went to a universal health plan and calculate the savings based on all of those assumptions, because they're not all the same for us. So is there a way that you think we could do the calculations as accurately as possible for something that has not been implemented in the United States in a state yet? How would we go about getting that specific calculation? What would your recommendation be?
Michelle, you ask an excellent question. We cannot just take the experience of other countries or Kaiser. For example, Medicare and Medicaid covers 55% of your people in Oregon. You have to take all that into account. That's bad news. The good news is that's what the economists can do. Actuaries actually do not do that kind of work. For example, right now, New York State is considering it. They contract out the cost estimation to a research group at University of Massachusetts, applied econ group. To me, you can, again, go back to Milliman, ask them to do it, but ask them to bring in economists who are knowledgeable to carve out the public sectors in America. Federal government handles a large portion of it. There are already existing institutions and do a very careful job rather than just theoretically, we're going to build a new agency.
I'd like to tag on to that. I see your hand, Mike, too, but so I agree with Michelle, that is kind of a stress, and I fully accept your premise that there are all these savings, Dr. Shaw. I agree with all of them. They're definitely there. However, as a single state in a federal system, we're also going to have new administrative costs that wouldn't exist if this were a single payer system on a federal level. Medicare and Medicaid, as you alluded to, will still exist. And even if we get waivers for them, we're going to have administrative regulations that we have to follow in order to fulfill those waiver requirements. Because of ERISA laws, we can't require that self-insured businesses participate in a UHP. And so it's very possible that those plans will still exist. We have residents who live in Oregon but work in other states and want to keep the insurance that they have through their employer that's based in another state. And similarly, Oregon businesses have residents as employees and they also have non-residents as employees, and they're going to have to wrestle with some of their employees need health insurance coverage and some don't because they have the state UHP. And of course, we'll have visitors to Oregon and people who move here just for the healthcare. There are many administrative complications. A unified claims processing system would be brilliant, but we'd have to build it, right? So there are new costs to a UHP in a single state that wouldn't exist if we were doing this on a national level. So I appreciate your point about getting an economist's point of view, but I think we have to consider the costs as well as the savings when we estimate what that could be. Do you agree with that, or am I missing something?
I agree with you. That's why you are looking for the net savings. When I say, let's say Taiwan has only less than 2%, or Medicare administrative expense is 1.5%. There are also these problems like visitors, people with other insurance, all of that. So you're correctly pointing out, there are these other complexities. Then the question is, do we have a system already handling it? Or we have to actually have a new system? The way Milliman reported is you're going to build a new system completely from scratch.
Well, just to clarify, that was dictated by the legislature that created this board. They put in the legislation that it will be run by a public corporation. That wasn't Milliman's idea. That was the legislation that they were following.
Yes, I read the report, not as thoroughly as you have. And, but then let me revert back to when Vermont asked me to design, we went into that in great detail with the legislative planning staff. And we actually look at the different rules. Medicare's payment rules would be most of it you will adopt it. It's the Medicaid rules that can actually, because they, your qualifications based on your income and also the benefits is determined by each state. That could be actually more complicated. These complications can be built in. It doesn't cost that much money. And if I'm doing it, I will put out a competitive bid rather than assume we're going to build a completely new system, public system from scratch when decades of experience already accumulated, expertise, as well as operating systems and procedures. You want to control the policy. You want to control the finance. You want to control the quality of healthcare. You want to control the access of healthcare. but you don't want to control the paying the claims. That's why I urge your governing board rethink of that issue. And there's significant savings, in my view.
Thank you. Yeah, go ahead, Mike.
Again, thank you, Bill. It's wonderful to see you. I just want to kind of build on Helen's question to ask something more specifically. We can conceptualize this universal health plan in terms of the 5 dimensions you mentioned, you know, the policy, finance, access, quality. And at the same time, a number of us have observed that our state does not necessarily have the greatest core competencies in terms of some of the other dimensions. So what if we take your suggestions, create a universal health plan board, but in partnership with some of these other organizations? You describe it as competitive billing. I could frame it as I want to partner with someone who really can do IT. I want to partner with someone who actually can get the monopsony advantages of pharmaceutical purchasing as when I was at Kaiser, when we did negotiating with Merck or others. I want you know, someone to be that might currently exist, bidding on doing whatever policy and financial framework we do to administer things, whether it be claims or global budgets or other variants. So could you comment on the you know, as organizations start and then as they grow and evolve, you seem to mention competitive bidding, or could we just design something that would literally be from the start a public-private partnership? If you could comment, I'd appreciate it.
I like the way you framed it. It ought to be a partnership. And but when you select your partners, you may want to do a competitive process to say who actually are willing to partner with me and how much it may cost me. And select on that basis. When I said competitive bidding, I meant is actually you specify the scope, then it's not a partnership. So I like your idea. And that's what German did when they take their 3,000 different insurance plans into a UHP. They partner with their so-called sickness funds, and sickness funds then reduce from 3,000 now down to about 150.
Thank you so much, Dr. Shao. We need to move on for our agenda, but we really appreciate you taking, oh, sorry, did you have a question, Judy?
I can hold my comment on whichever works, either
Okay,
I have a comment about the same, but.
okay.
Well,
We really appreciate your time and being here today, and thank you so much.
thank you for listening to me and give me this opportunity to give you my view. Okay, bye.
Okay, I will. Okay, great. So we have a little bit more time. We have about 20 minutes to go through some other ideas about administrative savings before we take our break. I'll hand it over to Mimi.
All right. That should be on there. Got it.
All right, sorry about that. Much better, phew. Yes, no stress, to go after the internationally renowned, honored Dr. Chow. I also am incredibly grateful, yeah. However, we're going to talk about a portion of what Dr. Shaw talked about. So truly just about administrative savings. And I am lucky enough to have had the opportunity to also go over this with Professor James Kahn. He's a professor emeritus from UC San Francisco, and he spoke at our transition committee meeting as well. And actually the slide that that Dr. Shaw referenced is mine. True, it came from my slide deck. My slide deck came from Tim's paper. So that one slide was really Dr. Kahn. So I just want to be clear about that and give credit where credit is due. So I am going to go through pretty rapidly the presentation that we gave to the transition committee, excuse me. And I think, and I will also like to present to the board some of the comments and discussion points that the transition committee brought up around this. And if we go on to the next slide, what I hope that we can do is to have the board agree upon a percentage or a range, just as Dr. Shaw mentioned, of total health expenditure that can be reduced by administrative savings under the current plan proposed as we have it to date. All right, so, and the rationale behind that, why do we need to come to any number? Well, we really do need to get this to be able to inform the revenue target. Now, again, you'll see my little asterisks. This is not the totality of savings. We're only talking about the administrative savings. So I'm not talking about those other areas that Dr. Shaw so expertly spoke about. So next slide. All right, this slide just goes through why. Again, we think it's important to get to some type of number around the administrative savings, because if you start with a status quo, which we have numbers about that, and then if there are savings, that those can potentially reduce the cost of the status quo, that gets us to our universal health plan expenditures. Then if we think about, all right, and then we get this money coming from the federal and from the federal government that reduces load, and that gets us to that replacement target, the amount needed to make up the difference of expenditures that less the available federal and state funds. So because we need that, so we can get to really be very specific around our revenue plan. So next slide, please. All right, this is something that people are aware of, in that, and if we look at healthcare expenditure as a whole, on average, administrative costs are about 25%. There's been multiple studies. Granted, some of them say a little bit more, some a little bit less, but this seems to be the happy medium. So we're talking about a quarter of the pie. So that's what we're talking about today. All right, next slide. So what changes how much of that quarter of the pie that you can save, have savings with under a unified payment system? This is where that work from Dr. Kahn, he looked at all of multiple different studies that actually quantify the amount of savings related specifically to the change that is related to a universal health plan. And I'll explain this in the next slide. So again, when you look at this, what you will see on the left-hand side are those billing and insurance related categories. So you get savings because there is changes related to billing, changes related to a formulary, changes in the quality system, reduction in challenges with provider credentialing, all of those things. And that's where, and this was the slide that Dr. Shao showed, that you get to that 10-ish% potential savings, both from outpatient clinician offices and from hospital inpatient. So next slide. All right, and what are the components of that? And this is, again, this is what Dr. Kahn's study really outlined. And this, if what happens is these are additive. So in the plan that this board has developed, one of the important components is that there's a uniform fee schedule. Well, that provides some savings. Well, also then going down, adding on to that, that there are uniform benefits. All of the people under the plan get the same types of benefits. And this particular one showed if all cost sharing were the same. And of course, there's still the discussion if there'll be any cost sharing at all. Next, you'll go down and it's additive and a single billing portal. Now you start to see those arrows adding up. that really starts to help with the savings. Next slide. And again, we're continuing to go down the list. What if there is that universal insurance card? So again, that question that comes up, as people talked about at the top of when you go to see a clinician, things are made easier, single formulary. I think if you notice on the far right, towards the right-hand column is where it shows inpatient. And again, hospital global budgets, we've spoken about this a lot. They're absolutely challenging, but have been very well documented to provide savings overall. And then, of course, at the very bottom, which is when in Dr. Khan's paper, he talked about the savings from payers. If you take away the insurer profits, that and also that all the benefits are the same, that's where you get a lot of saying on the what we call the payer side. All right, next slide. I wanted to pause just for a moment to talk about some of the payer side savings to keep in mind. So in Dr. Xiao's presentation, his amount was, I think, 5% of total healthcare expenditures could come from that the reduction in administrative costs and reduction in profits from the payer side. And again, apologies for a lot of acronyms here, but what we're looking at is something that's called the medical loss ratio, which is something that is used by health plans. Sorry, I want to come up to my very specific term here. Oops, there we go, sorry. But basically it's a way to attribute the amount of the total expenditures. The medical loss ratio is the percentage that goes towards patient care. And then the rest of it of that, if there's, and there are lots of rules that the medical loss ratio, some of the rules have to do with that. There must be at least 85% of all the expenditures must go towards patient care, and then maybe 15% goes towards either the a profit margin of that company or their administrative cost. So when we look at CMLR, so that means the part that the insurance company, the complement of the medical loss ratio that the insurance company spends, again, on their administrative costs and potentially on their profit. The reason I'm belaboring this, I think it's important to recognize the change that has been happening in the US with those MLRs and insurance companies, health plans. So if you look in 2016 to 2019, this is the data that was in Dr. Khan's paper. On average, purveyors of private health, commercial health insurance, their MLR, so what they had out of all the expenditures was 20%, Medicaid was 15%. We look at that 1.3% for Medicare fee for service. Obviously, Medicare is not making a profit. Medicare is through the federal government, they're not making a profit. Medicare Advantage, on the other hand, those can be, they may not necessarily be for-profit companies, but those are private companies that administer Medicare and then also Medicare Part D. So you'll look at that medical loss ratio. Don't have all the data for all of those. However, once we move it up to 2024, what you will see is that that amount has shrunk dramatically. And I think that that is, again, something to recognize. So again, that big potential area of savings that is to be looked at now is perhaps not as great as it was back in 2016 to 2019. So that was a long way of saying that, but I appreciate you coming on the journey with me.
Why the change?
Go ahead.
Oh, just
Yeah,
why the
question.
change?
Why the change?
Yeah,
A couple of things that have to do with the amount, sort of the cost of healthcare. So if your administrative costs are kind of the same, but but the thing that you have to pay people for keeps going up and up, that's a big part of it. And then also it has to do with the types of reimbursement that those companies are allowed to get from the federal government too. That's a big part of it too. So it's a great question.
And just a clarifying point, so when we talk about CMLR, we can think of the CMLR as the total administrative spend on the payer side. That as a rough thing, that's the administrative spend. They're paying 80 to 85%, you know, for medical care, and then they're keeping these numbers, you know, for various sectors of the health insurance for administration.
Administration and potentially profit.
And potentially profit, yes, administration and profit.
And marketing too.
I'm sorry.
Yes,
Marketing.
yeah, marketing
yes,
is part of that.
Right. So, but these are the total numbers. So if we look in the blue right-hand column, 15 and 12% for private, Medicaid 9%, Medicare 10%. And what we need to decide today is how much we want that to go down. So that's the total amount, but we need to decide how much we think that of that is excess. We can't eliminate that entire amount because there still will be some administrative costs. But we're talking about the excess administrative spend that we want to reduce. And just to highlight also what Mimi said, that while administrative costs are astronomical, we do have to keep in mind that healthcare costs are outpacing those. What we're spending money on in terms of utilization and the actual cost of services has changed dramatically, certainly since the pandemic, and even in the last 5 years with cancer drugs, biologically active drugs, and then the cancer treatments. So we have to be really careful about that because we don't want to overshoot. Yes, go ahead, Chairman.
As we are considering this subject and regarding what's the reasonable number, percentage. Just keep in mind, as me mentioned, to explain to Emmy's question, why there's a CMLR decline by 2024. And one key reason was not intentionally reduce the retention of that part, but it's more of the inability to control the high rising medical costs.
Right.
Mhm.
That means between 24 and 2019, there's a significant expenditure increase
Right.
in medical costs.
Right.
And that can also translate to those retention where the percentage decline, the actual number actually increased.
Oh, yes.
Yeah.
Good
Yeah.
point.
So we need to keep that in mind. And so
Yes,
where we are,
that's a
only-
good point. Yes.
Right,
where we are only considering the BIR part.
right.
But as Dr. Xiao mentioned, the other part are inseparable
Mhm.
because the current status quo is incapable of controlling costs, whereas a single payer unified system is capable.
Yeah, yeah.
And so we need to take that into consideration. It's not just the percentage, but also the total amount.
Yeah, thank you. That's good. Quick time check, we have 8 minutes.
Okay. Good thing I speak quickly. I'm sorry, Mike.
Two quick comments. One is just my own historical preference that as we're thinking about a single payer, I want us to stop using terms like medical loss ratio in terms of where we're going. I absolutely agree that's standard practice, but we used to have things called community rating and other things that I think are more valuable as we think of this. The second point is that if you look at this stuff historically, I would acknowledge, but I would not overplay a data point for 1 year, 2024. I think it's actuarially more appropriate to look at things over like 5-year period things. So yes, that's a reference point, but I wouldn't extrapolate and say that, you know, the sky is falling or
Right,
whatever.
I mean,
stuff.
I would point to some examples such as Providence. You know, what I'm trying to get at is the broader picture.
Yeah, and as I mentioned before, I absolutely agree that I hope we have the flexibility here to have dialogue that includes things like, what do we do? Are we mere participants in seeing the system imploding like Providence? Or can we begin to creatively have some strategies for how Oregon actually can respond to this more proactively?
Absolutely.
That's
Why y'all are here. Thank you. All right, next slide. All right, this is a slide again from Dr. Khan's work, and what it alludes to is, again, as I was talking about, in the way that a health plan is developed, all payer rates, you save some money, but then you get the same benefits, then a single billing portal. I think I said that enough, but anyway, they're additive and they come up to a substantial amount of administrative savings. And Mary Lou pointed out very succinctly, she said, that looks like about 10%. And the answer was, yes, you were right. So about roughly the estimate, this is for a study that was done for California, they predicted under a universal health plan that a universal health plan administrative savings all put together would be about 10% of the total healthcare expenditure.
Yeah.
So we're all talking about the same thing. Next slide. And I say that right there. This is from, again, Dr. Kahn's. If you look, it says total 9.6. Now, the interesting thing on that side, the provider side savings came up to 4.3% of the total healthcare expenditure. Now, the providers savings on their own was a bigger percentage, but we're talking about total healthcare expenditure. And then the payer sides, 5.3 again of total. So coming up with that roughly 9.6% number. I would note that the payer savings were based on a Medicare fee for service of 1.3%. So just so people are clear, this is a very, very, very efficient system. Next slide. All right, and this is a roundup of a lot of these studies that have happened. I will say that the top two studies, the Wool Handler and the Himmelstein, both of those were looking at the United States against Canada. So, and what could be the potential for savings. So again, not necessarily a single state, but if we're to be like a unified country system. The reason I put the asterisk by Himmelstein, as I mentioned, if we were only looking at 25% of that pie, how did they save 25%? The Himmelstein study, their estimate of administrative costs was around 34% of total healthcare expenditures. Yep, I know, sorry, thank you. I keep going. I have in there listed also the estimates from the Optimus report. That was 8 to 12% excess total administrative spend. And then just lastly, when we look at the bottom, Dr. Kahn, the reason there's 3 asterisks by the 2010 study at 7.2%. He later participated and is one of the authors of the study right below it, the Jawani study, where it came at 12.4% savings. And Dr. Kahn said that that second study really supersedes just with additional information. So he felt more like it was that 12.4% was more accurate. Next slide. So this is what I put in front of the transition committee. What is a reasonable estimate for now? And I just threw these up as examples. Time to make a recommendation. You could either come up with one number or a range. Conservative, middle of the road, ambitious. Those were, based on the data that we have looked at. And again, just for administrative savings, not talking about the rest. Next slide. And our fantastic transition committee had some great input. One, to what extent can we factor in advances due to EMR and AI and the plan working as a monopsony? Another really important point that Mickey Dirting brought up was to clarify that this estimate is being proposed of a mature system. It is not talking about startup costs, personnel transitions, any of that. And her point was, as we go along, you may need to consider this needs in phases. Another member brought up the potential for, it would be great to get Oregon specific analysis because a lot of those data are a national analysis. And then lastly, making sure in the estimates, when we get to sort of our grand reckoning reconciliation, making sure that that provider collectability improvement is accounted for, that is, that it is clear, is that included in the administrative savings or is that something separate? So I think that's something that needs to be clarified. Next slide. Here's what they came down on. Nobody on the committee thought that the conservative estimate was correct. Most members were split between either middle of the road, 10 to 12%, to middle to ambitious. One member said, absolutely. There's bloat on both sides. I'm going with the ambitious. All right, next slide. So now we're going to put it to board members who would like to weigh in. Now, this is not legally binding. We are not voting on this, but to get a sense of again, this is gonna help inform the work that is done. And I think that it would be, if people have, this is a great time to contribute where they think, and if our transition committee board members want to change their thoughts, they can do that as well. But I'd love to hear from the people who are not on the transition committee first, so they can weigh in with some of their thoughts. So go ahead, Judy.
That's okay, I mean.
Yep, fire away.
Okay, so
Okay,
I'm
fine.
gonna change my position from the transition committee, based on current state. So I appreciate Dr. Chow's vision of that steady state savings of a true universal health plan, which is not what we are targeting for going from current state to implementation. And the comments from the transition committee considering even early implementation being more costly and probably not accruing all of the savings. That being said, thinking about the current state in Oregon, the average operating margin for hospitals in Oregon is minus 0.3% to 0.1% on the positive. That's not even, I mean, I don't know how you can make the analogy of razor thin being any more accurate for operating margins for hospitals. 70% of hospitals in the state of Oregon are losing money this year. There is no conceivable reality where hospitals will buy into a system where they're going to be paid less. I think I'd like to challenge the board to reframe our thinking about provider side savings as access stabilization, stabilizing what we have for providers in this state currently, allowing them to retain that savings so that they can build accessibility. Maybe some decade down the road, when we have a true universal health plan, there can be a renegotiation. It absolutely should be with the universal fee schedule, but we cannot account for provider side savings accruing to the health, which is why I will change my position to conservative.
Thank you. So do you want to tag a number or a range, or what do you mean by conservative?
Oh, I would even say 5%, but I'll agree with 7%. Savings is the most realistic estimate. For like phase one. Well, we haven't broken into phases, but yes, the most real that we should target.
And again, the purpose of this number is to give LRO a number to work with as we're trying to build the gap in our funding to what is our revenue strategy trying to fund? So we have to give them an estimate of how much we think what is the total dollar amount that we're trying to cover with our revenue strategy. So this is just to give them a ballpark. I want to also say that I really appreciate Dr. Shaw bringing this up. We have already talked about this as a board in our original sort of RFP, I should say, for our economic analysis. We had built in an economic analysis of how a UHP would affect the whole state, which would include what he said about what are the potential savings. That was built into our original RFP. It had to be dropped from our contract with Milliman. We weren't able to fulfill that part of the contract, but it is now built into the POP for the 2027-2029. So we acknowledge that we are not necessarily equipped to make this call. We're just giving a guess so that LRO can give us some numbers to work with. And then in our next phase, we will have that economic analysis to be more specific about what kind of savings we can expect to accrue. So right now, our job is to give LRO sort of a rough thing of how much we think is excess that they could trim off the expenditures in terms of coming up with that gap of funding that we need to fill in with our revenue strategy. Does that make sense? Okay, tell me, what do you think?
Just a quick comment about, as we discuss or even make a provisional decision, keep in mind two important issues need to be decided separately. One is what do we agree the estimate of administrative cost saving? So that's one issue. The other issue, as Professor Xiao mentioned, who should benefit from that administrative saving? That's a whole separate issue. And we should not mix the two in the same decision. That should be decided totally separately. In addition, I appreciate Judy mentioned about how hospitals in Oregon are struggling. But keep in mind, once we implement the universal health care, besides administrative saving, at least all the 4 other dimensions that Professor Xiao mentioned, that will help hospital and providers for example, they will no longer or dramatically reduce the bad debt because everyone will be covered. They will, not only that, they will get a timely payment. So there will be additional saving that will benefit provider and hospital, not just administrative saving. So when we are considering who should benefit the administrative saving, that other parts should be considered. Those 4 other dimensions that Professor Shah mentioned. So that's my comment.
I agree with you, Chunwei, and I would say that what we need to think of is what is our best guess about how much of that excess admin spend is there that we could reduce? What is that rough number? But I think our second point that we need to consider, you're right, that the who benefits comes later. But that second point is how much of that spend are we willing to relinquish in terms of our revenue strategy, right? So for instance, let's say we think there really is 15% savings there, so there probably is. But are we willing to tell LRO, chop 15% off and we only need to raise, whatever we came up with minus 15% and then build a revenue strategy that may be short, right? Like, so even if we believe there's 15% savings, how much of that 15% are we willing to relinquish in terms of lost revenue? You understand what I'm saying? Like, so we could say that and say like, we think that's there, but maybe we're only gonna go for 10% because we're not sure how that's all gonna play out. Go ahead, Mary.
What do just real quick, what do you mean by relinquish?
Because the purpose of this discussion is to give the LRO, Legislative Revenue
Yes.
Office, a number. And so I'm gonna make up numbers here. Please, these are not real. These are just for simple math, okay? Let's say we think that right now our expenditures, our best estimated expenditures is 100 billion. It's not, but it's 100 billion. But we say, we think we can find 15% administrative savings in a universal health plan. So really it's only gonna cost 85 billion, right? And so now we're gonna build a revenue, and then again, making up numbers, let's say we get 60 billion from the feds. So the gap that we need to fill with our revenue strategy is 25 billion. Okay, so that's what we're trying to do. We're trying to find that. And so LRO, so we say, okay, if we did this HCPIT and this corporate activity tax and corporate income tax, will we get to that 25 billion? That's what we're asking them to do the math on, right? Just ballpark, okay? So what I'm saying is, so that's what I mean by relinquish. So we could say, look, it's gonna cost 100 billion. We think there's probably 15 billion in savings there, but we're not sure. And it's gonna take a while, and we have new administrative costs that aren't there. So even though we think there's probably 15% savings there, maybe we should tell LRO to plan for 10%. And say, okay, we think it's actually gonna cost 90 billion. And so if we're getting 60 billion from the feds, we think it's gonna cost 90 billion. So our revenue strategy has to come up with 30 billion. Because we just wanna be a little careful especially in those first few years, and not relinquish that extra 5 billion. You know what I mean by relinquish there? Yeah. So like, it's the number that they're using to ballpark is our revenue strategy on track to meet our gap. The money that we're trying to come up with.
All right.
Yes, yeah.
Let's go with Amy, who's
Yeah,
not on the
okay,
transition
yeah.
committee.
Yeah, so less about specifically the number question, but it seems like we are maybe at a point where we, like, the consideration of the phases and like what we propose in terms of a startup implementation phase, which,
We're not there yet.
okay,
Yeah, but go ahead, finish your question.
when and where is that conversation happening, I guess? and,
Later
like,
in the
really
meeting.
understanding,
Yeah, later in the meeting. too.
okay, all right.
Yeah.
That was my
Yeah,
questions.
yeah. Go ahead, Mike.
And first of all, I agree with Judy's concern about the hospital, so we need to factor that into our conversation. But that said, I know I've said this before, but I think we need to look about a period of time of over maybe a 5 or 6 year period as to what the rate stuff should be, because I think it's a different calculation in the first year of UHP implementation than it is long-term.
100%.
And I think one of the things that we struggle with as a board, and we are struggling with the transition committee is, so what is that rate? I mean, if everything happens at once, that's one thing. If it happens more gradually, that calculation itself is something else. Now, my last point with this, though, envision, if you will, you've got a 5 or 6 year budget piece. Then you've got to ask, well, are there some particular calculations that you need for basically transition and maybe first year? And I suggest that's a different
Those are
calculation.
startup costs.
Well, it's startup plus maybe first year implementation, depending on whether it's big bang or not.
Right.
And I just think that we're gonna have, we'll need a more nuanced view here as to what's the ultimate calculation in terms of administrative costs and which things are accomplishable early and what investments does the state need to make to yield that as soon as possible.
That's right, and that's where the economic analysis comes in, that's gonna happen, and that's what I was mentioning. So Cheryl, one more comment, and then we're gonna go around the room and give a ballpark estimate, and then we gotta move on, go ahead.
Well, I was gonna say, I was all in on ambitious after hearing the presentation, reading the materials. But I do appreciate the situation hospitals are in and other providers actually. That said, I think there's a lot of work to be done on the business models of hospitals, executive compensation, ownership of hospitals and clinics. And pharmaceutical funding, we can do a lot on that. That's not even included in administrative savings. So I guess I would say, I'd be open to going to the upper end of middle of the road. That's.
Okay, let's go around the room, and you can say a number or a range, we gotta move on. Go ahead, Cheryl.
12%.
Not legally binding, again.
Yeah. It's not-
Don't at anyone.
Mike?
I'd like to make the point that maybe it's not clear to everyone, when you look at things over a 5-year period.
Right.
You've got to also assume that if costs are going up by 5%, you don't have to reduce hospital costs. You can just not raise
Got
them,
it.
so
We just need to give Ella Rowe a ballpark
yeah,
to start with.
so I'm gonna stay with 15%.
Okay. And Mary Lou?
I'm going 13.
14.
14? Okay, my number's 8.
7%.
12.
Oh,
Michelle.
Amy 12. And Michelle?
I'm gonna say 10.
Did we help you?
Thank you.
On average.
Thank you all. We are going to pause here, take a break. It's 10:42. We're coming back at 10:52. We've got a lot to cover in the second half. Thank you all. Okay, welcome back everyone from the break. We are going to be moving on now to our next topic. We have some updates from Echo Northwest regarding the final report, and then we're going to get into a discussion about our revenue strategy. So I'm going to turn it over to Morgan. And Morgan, before you start, I want to thank you for your patience. You've been on the agenda for the past couple of meetings and gotten bumped more than once. We really appreciate your patience with this group and your willingness to stick around with us. So thank you.
It is my pleasure. Hard things are hard things, right? So glad you help make sure you guys have time to discuss. And so we have a short little sort of just kind of more update here. I think I'll be coming back to you some other time on talking about reserves, but the first part here is just to give you a sense of our draft report that was part of your materials, and then also talk a little bit about something Chair Blanca mentioned earlier about the role that the Legislative Revenue Office will be playing in helping you take the revenue proposal and support your deliberations going forward. So first, I want to say a couple of things about what our report is and what it is not, and I'll probably start with what it is not. Right, it is not a formal sort of submittal on the part of the committee members themselves, right? We think of this as we were contracted to support the Finance and Revenue Committee, but also and the UHP board. And the report that we were required to do is really kind of do two things: simply just provide sort of documentation of that process, as well as provide some analytic work related to sort of business and household distributional effects. But the product itself, I think, is a nice point in time product where folks can understand what the committee had been doing, the nature of its deliberations, and some of the outputs of that work that have flowed through as a set of revenue proposals to this board. And so at our last meeting, the committee wanted to make sure here, right, that they took a 5-2 vote here, that the committee does not formally approve or disapprove of a report. They were supplied with it in draft form so they can understand and incorporate those comments, and we did. We had a few board members actually do some pretty substantive sort of comments in writing, so we greatly thank them for that. I think it's also worth acknowledging, right, that the committee did not, felt strongly that they did not complete its full work and only delivered one of their two deliverables, but specifically not all the tasks they were charged with doing. And so I just want to get that out front. So that said, what is the report? The report is a pretty full documentation of what the committee did in terms of its process, its work. But there were really kind of, I said, 6 really key pieces that are in that report that are worth this group spending some time on. The first one, I think here, right, is a concept that we are calling the revenue, two concepts. The first one is the cost target that you obviously is flowing out of the work of some of the committees, but is currently in the board's process of what will the UHP actually cost. And then and then also a related important concept called the revenue replacement target. And so that revenue replacement target, right, is to say, well, there is a lot of spending on healthcare right now. We're trying to devise a plan that will cost less, vis-a-vis your conversation around the administrative cost savings. And we want to be able to sort of marshal those resources currently through various different sources: federal, state, households, businesses, and transfer that to a new plan, and then be able to sort of mimic contributions from businesses and households through a tax plan that would flow directly to the program. And so through the transferability of those existing resources, that revenue replacement target is that key idea here that I think is important to understand as part of that report. All that work that was done, and particularly thanks to committee members Charlie Swanson and oh my gosh, Richard, for all their work in carrying a lot of the heavy lifting, was anchored in 2022 dollars, which kind of was, think of it as like the best available information that the committee had to sort of do some analysis to work through some of these concepts. Ultimately, they arrived at a proposal that I won't steal the thunder on, but you will be talking about shortly here. The main heavy lifting is being done through an employer payroll tax that is meant to mimic the current contributions that are paid for by businesses for employee-sponsored health insurance, and then through a new healthcare personal income tax that has a series of household adjustments and credits that would be the sort of main sort of revenue tools that interact with each other. There are some additional supporting revenue tools through the corporate income tax, corporate activity tax, as well as a lodging tax, and they also interact with that system. You'll see, right, that proposal in the report has the set of parameters that are set there, and also estimates the amount of revenue raised by each mechanism, as well as sort of what the cost of those credits are that are provided in there. Additionally, there are 3 things that are also part of that. There is an impact assessment that looks at, as best we can, what the status quo is across different key categories of current users, so businesses, individuals, governments, and what that would look like in a UHP size. We further are able to then understand the sort of rough distribution of particularly business impacts, to look at firm size, industry, whether they currently offer coverage or not, as well as sort of how the healthcare personal income tax would interact with household impacts and relative to employment status and whether those individuals are currently in the Medicare population. We then put together, through a lot of work that Richard did, is a set of illustrative scenarios. And so these are kind of call them payer typologies, particularly at the household levels, that really are trying to understand different kinds of payers and how their incidence of payment would change from the current status quo to a UHP plan. And that kind of shifts that sort of kind of premium out of pocket to the sort of tax structure that is being provided. And finally, the last piece of work that we were documenting there is some analysis, original research that we did, as well as supporting the conversation with the Finance and Revenue Committee around reserve and transition costs. The deepest work there was made in thinking through the reserve strategy, and the reserve recommendation that the committee came to was a 3-month operating reserve with a 1-month trigger to sort of add new revenue, but not defined exactly sort of how that trigger would be sort of operationalized and what it would actually trigger in terms of recapitalization. The key element there with the reserve piece, I think is worth thinking through, that I think is a value add, is some opportunity cost on where those reserve dollars were coming from. And the committee really had a sort of a novel idea to think about it in kinds of kind of call it low cost versus high cost kind of reserve dollars. And the low cost ones, or think about them as sort of dollars that are currently in the system operating reserves, and whether there was ability sort of to transfer those things, or to provide some backstopping or sort of in some ways kind of paper reserves for more volatile times. So basically the state's rainy day fund and other sort of reserves that are in place that would be tapped under certain conditions, but would also form that. And then the last kind of tier, right, are those high opportunity cost ones. Would there be specific new fees? Would you run the tax earlier? Would you run the tax a little higher for a certain amount of time to generate those reserves as the plan begins to ramp up over time? And I think some comment earlier here, right, is in both the revenue design as well as the reserves, there is some understanding, right, is that what it means on day 1 versus day 10, year 10 of the program is going to be different with respect to how much revenue you're going to need at any given time and what those reserve and recapitalization needs are going to be. So I'll just pause. It's a very long report. We tried to be as thorough as possible to document these pieces. But before I kind of move into our next step, are there any kind of quick questions? Otherwise, I want to talk a little bit about the work we're currently doing with LRO. Great. All right. So I'm going to borrow a convention from the engineering field, and they tend to think about sort of projects in kind of a percent design, where 10% design is really concepts, idea, planning level kind of estimates to kind of understand what your project is, all the way to kind of 100% design, which these are kind of like construction drawings that you could hand to a contractor to kind of go build something. And I think that analogy is apt for the process that the Finance and Revenue Committee worked through, is really to try to get to some sort of less than 10% design, right? To talk about these key ideas, do some modeling that would support the understanding of how much revenue, what the rates would be given the tax base, as well as what the distributional impacts would be against businesses and households. And all that information is super, super valuable and supported the committee in those deliberations. As we kind of move into this next phase, you're trying to get to a little higher level of design, particularly in getting a package that is ready to go to the state legislature when you submit your report in September. So working with Chair Blanca and Executive Director McDonald, we decided to make sure to reach out to the Legislative Revenue Office to basically help advise and support the board moving forward, so that you can take that best available discussion and revenue proposal that Finance and Revenue devised using kind of that 2022 calibration and move it forward to a proposal in 2032 that is as legislative ready as possible. And let me talk to you about the process that we are going through with LRO. The first one, right, is really trying to lock down the technical definitions of the taxes themselves. The work that committee member Charlie Swanson did was fantastic, right? He done a lot of great work to understand the tax base, the mechanism, but there are a whole set of rules and other issues that we have to kind of make sure we kind of refine to make sure that that proposal is ready. And so this is one of the things this is the step we are currently working through with LRO, is really to like clarify those questions of like, what's the tax base, right? When you say, for example, what is the tax base of the healthcare personal income tax, right? Are we using federal AGI, less the a set of deductions for Social Security, pension income, other income, to kind of get to Oregon basis, or are we using something a little different? Both, I think that was kind of the work that Charlie done. We start with federal AGI, but we're making some adjustments to that. And so here, I think we have a process of just trying to get really clarity. And the same thing with the employer payroll tax, right? What is an employer? What is a firm? How do we treat organ employees versus non-organ employees of those businesses? And so we have to make sort of these sort of real clear technical definitions of the tax base so that we can understand what's taxed and what should be excluded. And we are working with Charlie and Richard as part of that process to make sure we understand kind of the intent of those proposals in the conversation, and then to support kind of LRO, making sure those technical definitions are correct. And from there, right, we can make sure we understand both the rates, the current rates that are being proposed and the credits, as well as sort of making sure from their perspective, they're saying, well, okay, well, what are the right conditions? What are the key legal things we need to make sure we're clear about and upfront with, so that we can get to kind of call it a clean spec of the tax package that LRO then can run consistently with you all as you solve for different kinds of things. Because that's the next piece, right? Is then to move that proposal that we have into 2032. So here, LRO has a series of models, right, that they use currently to work with the state legislature when there are requests for different revenue packages. And so these tools and these conventions are there, and we want to make sure we use them, because when the proposal goes to the state legislature, these are the things they're going to be doing. It's also important to note here what is being produced are what we call tax liability estimates. So basically, they look at the tax base, they look at the rate, and then they say, under that best information, what would be sort of the revenue output. It is not a dynamic model because in a couple of ways, there isn't one that exists. And two, the proposal that we're talking about here are leading to some pretty fundamental different ways that the tax structure will work, particularly with thinking about rates in the healthcare personal income tax, even though they're meant to be sort of, hopefully not revenue neutral, but sort of generating less revenue than the current spending. The distribution of those things as it falls on households is going to be a little different, may introduce migration or other kinds of issues that places in like Portland are currently experiencing. So we don't have that sort of dynamic sort of feedback loop, but we will be trying to provide some context for those things as part of the work going forward there. So how does the board then interact with this? And I think Chair Blanca talked a little bit about this already, but you're going through a process to say, well, what is the universal health plan going to cost, right? How are we able to transfer, preserve that funding? And could we particularly save money in areas, right, that will then change our 2032 revenue replacement target that even though we were solving for about 17 billion in 2022 dollars, perhaps those decisions would result in a target of like 15 billion in 2022 dollars. But then we would move all that forward to 2032 to understand what the revenue is. And because LRO has those forecast models, they can take that revenue and then solve for the rates that would need to be in place, given what the finance and revenue and what the board here would propose. So think it is basically a process where we try to get to that revenue replacement target, understand what the tax base looks like in 2032, and then say, well, what are the resulting rates? And then some interaction with you to kind of say like, well, proportionally, that's where finance and revenue left it in terms of kind of the split between the EPT or the healthcare personal income tax, and that resulted in differing kind of rates, and maybe you want to change that sort of distribution of things. And so all that sort of work is currently in place to kind of support you in the next few months as you deliberate along those lines that are going to basically change the recommendation you have to the legislature on the revenue package. So I'll pause there and take any questions a little bit on terms of what we're doing currently with LRO. Hopefully that's clear, and what that path looks forward here in the interaction with the board going forward. Okay. Clear as mud.
Yeah.
Right. Mimi, should I give a quick update on the tax calculator as well?
Yeah.
Great.
Sorry, please.
Yeah, so as part of the communications process and to support engagement, once the board has made a decision on the revenue package, is we will be standing up a website as part of the UHP conversation that allow folks to do, I think, two things. One is to understand a little bit about how they and their employer, if they so are providing it, are paying for healthcare today, right? There is I think it's important for folks to understand, particularly in the context of a new set of taxes, that there is household and business spending that is being used today to pay for that healthcare that they are going to consume or have consumed and will consume going forward. And then we want to be able to introduce the idea of the universal health plan in the context of how some of those dollars will be transferred and then need to be sort of reconstituted in the revenue replacement as part of a set of new taxes. And so for households and businesses, perhaps, you could basically enter in information. So think of it as basically, oh, well, I am employed, my employer is paying X dollars for my healthcare. I am paying this much as part of my premiums. Here's my out of pocket. And then enter some just scant details of their income and age, so that we could basically then run a tax analysis so they can understand what it looks like for them in the status quo, and what it would look like for them in a UHP setting. The idea here is not to be sort of explicitly precise with anyone's given situation, because everybody's situation is complex and the tax is really complex, but we really want them to understand the key parameters. So what happens when household size changes? What happens if income changes? Right. So think of a series of sliders and things like that, where they can understand the distribution of kind of what's being paid today, what we'd be paying for and going forward. So they have a better understanding of the proposal and the key aspects of that, and particularly across themselves and particularly other kinds of households, so they can understand the distributional effects a little bit. And so we're kind of working with DCBS IT web staff right now to make sure that we are producing a compliant tool but we'll be working closely with Chair McDonald and others on UHP staff to get that built here in the next couple months.
Morgan, do you have that calculator to show, or is that still in the works?
That's in progress. But if you look in the report, there are the typologies, and you'll see kind of a sense of kind of where we're going to be heading with that.
Great. Oh, sorry, Mike, go ahead.
Thanks, Morgan, because I haven't been on your finance committee. I actually, believe it or not, read your entire report last night. And I have a question. It's on the tax calculator, but it's really on a larger issue. The report assumes some rate for the individual income tax of about 10%. And we've just had a clear verdict of the Oregonians. They certainly didn't want a gas tax. So my question is, if, as we've just started the deliberation of reducing costs and administrative costs, if I'm just gonna take some crude figures that Richard and you are clearly better than me in doing, but if we were able to reduce $2.5 or $3 billion from that 2022, I did a back of the hand calculation last night. We could, and just use those savings to reduce both the individual tax as well as start to try to fund the transition costs. Is it possible to have candidly a calculator that not only includes what it's like if the individual rate was 10%, but if it was 6 or 7%?
Yeah, correct. I mean, so I would say that is the substance of the work we'll be doing with LRO to make sure you understand sort of the implications, right, of the different rates with respect to kind of what you need to raise to pay for the plan. And then ultimately, right, you can reflect those different kind of conversations or scenarios as part of the tax calculator that would be more public facing. Right. So I think it is, yes, on the technical side, that is what we're setting up to do with LRO to support the board and its conversation going forward. But then we can obviously reflect that publicly, however, makes sense as part of your public communications and outreach approach.
Thank you.
Yep.
Can I just clarify there too, though, that we keep using this number of 10.1% and really, that's not the right number to focus on. There really is essentially nobody who's going to pay 10.1% personal income tax because we're excluding that first 200% of the federal poverty level. And so even if you look at Exhibit 26 in Morgan's report, it shows how much people will pay at various income levels. People making $50,000 have an effective HCPIT of 2%, right? And people making $100,000 have an effective HCPIT of 7%, right? And even if you get above $500,000 in income, you're still around 9%, between 9 and 10%. And so really those higher levels, the 8 to 10.1% occur only above, when you're hitting $300,000 or more of income. And for the overwhelming majority of Oregonians, somewhere between 2% and 7% is probably their effective HCPIT because of the way it interacts with the removing that first bit of income.
Yeah.
So yeah, we need to keep thinking of it that way.
Well said. Yeah, that's just the headline rate, but the effective rate, because you're using your two definitions of what counts as income and what counts as credits, changes everybody's effective tax rate.
Go ahead, Mary.
I'm with you on that on Helen, but I'm asking about Exhibit 28. So those numbers are a little different than what you said, and so I'm trying to find what the discrepancy is. Okay, because it appears to me, if I'm reading this table correctly, that people making over 500,000 income after taking out the first 200% FPL, et cetera, are paying 9.2%. Is that correct? Is that so? And down at the 125 to 150, it's at 8 effective rate of 8%. Okay, they were just a little different numbers than you were.
Well, I was ballparking based on the total dollar amounts on 26, but yeah, this is actually calculated
This
out.
part is
So
what I should
and
be
it's also
telling people.
right, yeah, look at this chart, yeah, so
Right.
if you make 45 to 50, it's 2.9.
Right,
exactly,
exactly.
right.
Then my question is, explain to me why people down at the 0 to 5, and especially the 5 to 10 are paying 1.8, and then it drops down at the 25 to 30. I don't understand that.
I'll have to double check with that, but and Charlie, I think that if you're on, I think that's the effect of the HSRR.
Oh, okay, this still has HSRR in it.
Yes, it's part of the
Committee
proposal.
voted to keep it in.
Yeah.
Committee did, yes. Okay, thank you. That explains it. Thank you. It's a great table. It's a great table.
Yeah, and just FYI, all your work with LRO will have similar tables with their models as well. So you'll be able to see a lot of the same distributional work.
Right. The average AGI in Oregon is around 85, 80, 85, I think, median, not average, median. So I think, so that puts you at like 5.5%.
Right.
That's all I got, Chair.
Great. I had a question, Morgan, about the HSRR. Being that right now it's calculated based on exemptions, which I understand have since been eliminated with HR 1 at the federal level. But we had talked about sort of shifting from exemptions to sort of dependents. But that would change because they're not exactly the same, right? You can claim an exemption for yourself and your spouse, even if your spouse isn't a dependent. So it would really shift toward children, right? Or sorry, I don't mean, but dependents really instead of exemptions. Do you think that'll make a big impact on the effect of the HSRR by making that change, or is it kind of?
Well, I think too, this is one of the questions we're talking with LRO on how best to model it. And one of the ideas could be just offering, think of it as like a standard deduction type of arrangement that would work to sort of kind of mimic the idea there. So this is kind of the sort of like what we count as a tax base for all these things, and how would you actually implement it as a revenue tool? And so so all to say is, I think yes, depending on what we decide on, the idea of the HSRR, right, is the sort of revenue raised by it's going to be a little different depending on sort of how we translate that idea into kind of a tax base that can be tested. So it's going to move a little bit. I mean, Charlie did a great job just trying to figure out how to sort of get us in the right ballpark of what that would look like. But more work to do there. And I think we'll have some more things to share with the committee soon on that.
Okay, thank you. It's a great report. We really appreciate it. And yeah, a lot to dive into, and it's going to be super useful as we discuss going forward. So deep gratitude to you and all your staff for the work you did on the committee, and then also the work in putting this report together. It's just tremendous. We really appreciate it.
Yeah, thank you.
Will you be staying on for the next bit of discussion?
Yeah, I'll stay on. I'll be here to help the next conversation.
Okay, yay. So we have a couple of decisions to make. Mimi, do you want to take this, or do you want me to?
If you want to kind of do a high level, then I'll go through the slides.
Yeah, so I think there are 3 decisions to make today. One is, we got last month, we started our discussion about the household size rate readjustment, whether or not that should be included, and considered the committee's input and kind of what our philosophical leanings were. And so we need to kind of decide where that stands, because we didn't land on anything last month. That's number 1. And number 2, there's a piece about Medicare that we should discuss, and that, some information was sent out before. The committee had opted to have Medicare enrollees continue to pay their premiums and then get 100% credit, not a refund, for those instead. And there's some concerns about that, given that we're paying for everyone else's premiums. If you pay premiums through your employer or through the individual market, those premiums are covered by the UHP, but the premiums of folks eligible for Medicare Part B are not. It seemed like a little bit of a hard sell to me to ask them to continue to pay those premiums. Medicare Part B, of course, pays for ambulatory services, and they'll be able to access ambulatory services through the universal health plan. And so to say, we need you to keep paying these premiums, even though if you don't, you'd still access all ambulatory services that you need. And the reason we want you to keep paying them is because it benefits the UHP, not necessarily personally, but the UHP. that seems like a little bit of a hard sell to me. We want those premiums to continue to be paid because we get way more from the feds, from those premiums in terms of paid healthcare expenses than those premiums amount to. So we want them to continue to be paid, but I'm interested in the board having a discussion about whether or not the UHP should just cover the Part B premiums for all Medicare enrollees. That's what other states have done. If you look at New York's plan and Vermont's plan, and the assumption was that the state plan would pay for those premiums instead of having people pay them individually and then get a credit against their HCPIT. But those are the two main things. And then once we get through those two topics, then just an overall vote on the revenue strategy, so that we can continue to work with LRO to come up with sort of the actual numbers of how this is gonna work. Good?
Perfect.
Okay.
All right, let's get going. All right, so this is very much a summary of the information that is available in the Echo Northwest report. This is, again, using what has been used as the revenue replacement target. This is in 2022 dollars. And just a reminder of what we were calling the revenue instruments are in place currently. So the Oregon corporate income tax, Oregon corporate activity tax, the Oregon employer payroll tax, Oregon healthcare personal income tax, also a household size rate readjustment, and actually the board has not particularly voted on this one, the Oregon lodging tax. So next slide, please. So I provided this with the last at the last board meeting, but I wanted to remind the board of the board decisions that have been made already. Now, again, these were decisions of the preliminary proposal about what the board was considering, but I wanted to make sure people understood so far what the board has approved. So it's, as mentioned, it's those tax instruments. And then we can go into a little bit more specifics. That was in the November 2025 meeting. And the healthcare personal income tax, the decision was made to put the exemption threshold at 200% of the FPL. That was in January. Decided not to have a soft cap. That was also the January meeting, and that the employer payroll tax credit would be set at 50%, also in that January meeting. So next slide. So today, two things on the docket for right now: the household size rate readjustment and the Medicare Part B premium 100% tax credit. There was a lot of great information that was provided on both of these topics, so I am not going to belabor them too much, but in a nutshell, household size rate readjustment for upper income households would contribute more to a universal health plan based on their household size, which would reduce the burden mostly on the upper income smaller households. So that's the rationale. The mechanism was that using that Charlie just put something in the chat and it's in there. So for an additional 1,325 premium per exemption greater than one was phased in between 260 and 520% of the federal poverty level. My NB, note bene, the HSRR does not neither increase nor decrease the total amount of revenue that needs to be raised. It just depends on who is paying more within that bucket of people paying for things. In contradistinction, the Medicare Part B premium 100% tax credit, again, initially, the thought was that, well, people, if they should get essentially sort of the money back, although Chair Belanca is correct, it's a tax credit, it's not necessarily, it's not a refund. Since Medicare recipients are already contributing to a universal health plan, they should not have to pay premiums. And the mechanism would have been, the proposed mechanism, which has so far has been approved, was that they would be required to pay their Part B premiums, including the IRMA, which is for higher incomes, and they would get a 100% Oregon tax credit, non-refundable. So they would not be able to make money, but they would get the money back that they paid on these tax credits or under the tax. So next slide. So now that was both of those things. Right now we're going to focus on the household size rate readjustment. So arguments in favor, if you look on the right-hand side, favor of maintaining the household size rate readjustment. Again, shifts the burden of contribution to higher income earners with larger households would pay a little bit more. So that's a reason to keep it the way it is. That's the rationale. And the other rationale is if it were to be removed and no other changes were made, then that would necessarily cause an increase in the top level of the healthcare personal income tax, just because of the shifting. So again, it is not that more money needs to be raised, it's just it needs to be raised by different people. Tends to be, so there's a shift. If you look at Charlie Swanson included and we included it, there's a great spreadsheet that shows the changes. Arguments against maintaining it. One, it adds complexity, which is true as we're here discussing it. Two, as we have heard from public testimony, is considered counter to the principle that contributions are based on ability to pay, not based on utilization. There is also the argument put forth that this actually may encourage households to file separately. And then as Chair Belanca pointed out, it's the way that is proposed right now utilizes exemptions, which are not used currently to reduce federal taxable income. Although Oregon does use a personal exemption credit that is non-refundable. So next slide.
Can I just point out,
Oh,
there's a
please.
small typo here.
Oh.
And the arguments in favor, it shifts the burden of contribution from smaller household high income earners to larger household high income earners, right?
Well, it's an exemption more than one, so.
Oh,
It's when
from
it takes-
single, right, right, a
Yeah.
single person earning,
Yeah.
okay, I see what you mean by that.
Yeah, so, but you're right. I
Right,
mean,
smaller to
yeah,
larger, yeah.
yeah.
So if you have more, so the idea is like, is the amount you pay purely based on how much income your household makes? Or should there be a consideration for how many people live in that house, in the sense of if you have more people with that income, should you pay more? Because the idea is you're covering more people, should you have more, a higher contribution to the UHP because there are more people from that income, right?
All right, next slide. So I wanted to be clear about what the finance and, so again, the Finance and Revenue Committee had initially recommended this, and we're talking about the household size rate readjustment. At the March 17th meeting, there was a motion to remove the HSRR from the proposal. And that motion failed. So the motion to remove it failed, 6 no, 1 yes to remove. So it remains as far as where the Finance and Revenue Committee left it, that it would remain in the proposal. Again, the main argument had to do with the potential for raising that upper level percentage was one of the rationales behind why you would want to keep it in. So I am not making a motion. I just listed if anyone on the board was in the mood to make a motion. Those are some potential motions that they could make. And so I will leave it at that. I don't know if you want to say anything else, Chair Belanca.
Yeah, so just to clarify, it wasn't a philosophical decision about how much larger households paid. It was really because it would in effect raise the HCPIT. I want to point out that right now, without the HSRR, the UHP financing structure benefits pretty significantly larger households. And we do that because we've decided to exempt the first 200% of federal poverty level from the HCPIT. We made that decision. But the federal poverty level depends on your household size, right? And so as for a single person, a single household, the federal poverty level is roughly $32,000. If you have 2 people in the household, it goes up to $43,000. For every person in your household, the federal poverty level, the amount of total income that's going to be exempt from the HCPIT goes up by $11,300. So if you're a household that makes $100,000 and you have 1 person, right, you're going to get taxed on $68,000 of that because you just get that first 32 exempt. But if you have $100,000 of income and you have 4 people in your household, out of that 100,000, only 34,000 is going to be subject to the tax because we've exempted $66,000 based on that, because your federal poverty level is now $66,000 instead of 32. So just going from 1 person in your house to 4 people in your house, we have doubled the portion of your income that now that is not getting taxed with the HCPIT. So there is a substantial benefit currently. So the larger households right now in the plan do not, they pay substantially less for the UHP than do similar income households with smaller sizes. And so the HSRR would be tacking on a fee to those larger households, $1,300 per additional person versus the 11,000 that they're gaining from having a larger household based on that 200%. Does that make sense? Yeah, so it's a tiny fraction. It's like a 10% recouping of that fee. Go ahead, Cheryl.
Are you proposing either one or two? I'm just trying to get a handle on what your preference is.
I think this is,
Or, because I think I understand
Yeah.
your argument right now. I'm just trying to figure out what.
I think it's a really tricky issue, and I have really gone back and forth. Keep it, get rid of it, keep it, get rid of it, because I'm a big fan of the simplicity argument, which I think Judy has made a really good case for keeping this plan as simple as possible. I think there's a lot of advantages to that. I'm pretty shocked by how much the HCPIT goes down based on our excluding that first 200% of the federal poverty level. That 11,000 was a really shocking number to me. That's how much households are saving by having more, or not being taxed because of that. Right now in our current system, it's totally normal and accepted that you're gonna pay more for a family plan than an individual plan. That's kind of what people are used to and accepted, this idea that if you have more people that you're covering, then you just gotta cover more people. I think there's really valid arguments on both sides, and I'm really interested in other points of view. So we put these two potential board motions up there to think about how we could address this as a board. We could just say, we're just removing the household side rate readjustment, and then we're gonna leave the plan to sort of benefit households with larger sizes. Or we're gonna maintain the household size and try to recoup some of that money by charging more for bigger households, but we have to do it in a way that's different from exemptions as it's currently designed. So those are two possibilities. We could think of others. But yeah, interested in other points of view.
Okay, well, and currently you either have a family or you don't. It's not like, yeah, how many kids do you have? I mean, it's like you pay for the whole family, right?
Yeah.
Yeah. Okay. Thanks.
Go ahead, Wayne.
I really appreciate the comments here, and I drove down with Richard, and Richard tried to explain to me the pros and cons. And I'm just catching up to you guys, but I clearly appreciate, this is a very difficult decision. So again, going back to my kind of affordability mantra, I know I shouldn't use 10 before or now 11 now, but other people are not gonna necessarily buy into that in a political season. Can people comment on the fact that we're in the political season now? And I've listened to some of the Republican debates. They've all talked about no new taxes. I'm just wondering, to what extent should we consider that as a factor here, or is it not really relevant?
Yeah, with all due respect, I don't think it's relevant. I think we just need to kind of do our best job right now and make some decisions based on what we think is the right thing for the UHP.
Yeah.
And there's plenty of time to consider the bigger context later, but we've got some decisions to make in limited time, and I would rather us focus on, philosophically and sort of what aligns most with our principles in terms of building a UHP. What principles do we want to put forward, and how should we approach this question of the HSRR? Yeah, go ahead, Mary.
Well, I think you summarized it really well, Helen. And I do feel the horns of a dilemma here. I go back to, Lou's testimony and others, that's like, no, this just kind of keeps on that idea that it's, that's how insurance always has been. And no, it's not individuals, but it's family or single. I have a single daughter. I've got, a son with 3 kids. So it's like one or the other. And I voted for the HSRR when we were doing on the finance committee. I think and I can't remember, I think at the end, I was one of the 6 no's to take it away. But I do lean at this moment towards getting rid of it.
Sorry.
Because I think especially when you pointed out the part about when you do the 200% of FPL, how it really does take away, by 11,000 for kind of each additional member. So you really are getting a benefit from that the single person doesn't get. And when it lays out that it's really more shifting at the higher income levels than it is at the lower income levels. So, gosh, I'm really struggling, and I'd like to hear other people.
Yeah.
Chunway, good.
Yeah, just a quick comment before you say, our current estimates, and again, based on exemptions, not on dependents, is that it accounts for about 3.4% of our total revenue strategy. So again, like, it's not a
It's a
huge
small.
portion, but it's worth considering, but yeah, go ahead, John Wayne.
Yeah, I just want to clarify one thing about the HSRR. Well, in the finance committee, when we were discussing about this, there was another option that seemingly not included in that option. That is to keep the HSRR, but kept at the number of taxable family member. So let me give you an example. Taiwan's national insurance is primarily funded by payroll tax. So they don't have household income tax, but the payroll tax is shared between employer and employee. And then in terms of household, you have to multiply whatever your tax rate or tax amount by the dependent. But the dependent, they kept at 3. So if someone have, so the dependent, including if the spouse is not working, so you have spouse and then 2 children. So if someone have 5 children, still that tax it at the 3 maximum 3 dependent. So actually during the discussion, I proposed this as another option, but we didn't consider that option.
But and these were just potential board motions, so you certainly are welcome, nay, encouraged to make any motion. that you
So
would like.
that's an option we might consider to keep the HSRR, to put a cap on what's the maximum we are going to apply that.
Anyone want to propose a motion?
Well, I can propose this new motion that keep the HSRR, but we can't say it's 4. After 4, we no longer add more tax, including dependent.
Can I make a clarifying question? Would you consider maintaining the HSRR? Would you like to comment if that would be talking about dependents or exemptions?
It has to talk about dependents,
That's what I'm-
exemptions don't exist anymore.
Well,
It-
I just wanted to clarify.
Yeah, so it would have to be dependents,
yes.
yeah. And, consider changing the amount, consider whether or not there's a cap. I would just, I don't want to debate about the cap. I think the cap is a very political idea and will face some pushback, rightfully so, but I mean, just the idea that you would maintain the HSRR, but change it to dependents and consider changing the amount and consider a cap on that, but I don't want to debate whether or not there should be a cap. I think that gets a little into the weeds.
That was his motion though,
Yeah, right,
to put a cap on it, so.
right. Okay, okay, great. So.
And would you like, sorry.
Is
Would you
that-
like rise with
okay,
that?
Is there, okay, so you
So-
made a motion to keep the HSRR, but change from utilizing dependents instead of exemptions and put a cap on it? Is that your motion? Is that?
And do you want to
okay.
have a number for that or just leave that? The number of,
I propose 4, but we can have that
leave that
separate.
aside,
Yeah,
perfect,
we can
perfect,
have that
okay.
as a separate.
Yes, put a cap on the
Okay,
maximum
and put a
number.
cap on it.
Sorry.
Right, okay. Is there a second? No second. Okay. Does anyone else want to propose a motion? Mike?
Not a motion, but
Oh,
a question. So, the finance committee has looked at this. Is it possible to ask either Richard or Charlie to weigh in
Well,
on this?
they did with the, at the Finance and Revenue Committee.
Okay,
I mean, and
As I recall, when we voted 6-1, I believe Charlie was
the one.
the vote, the one vote, so,
Right, you voted to remove it.
right. Yeah.
And there's, in the meeting materials is
There's
his
a lot of stuff.
rationale for that, yeah.
Good, thanks.
Chair, I'll move to remove the HSRR from the revenue strategy.
I'll second that. Any discussion?
Oh, Michelle.
Michelle?
Thank you, Chair. I just want to state clearly that we are, in my estimation, in tension with two of our board adopted values and principles here. And I think that's part of what makes it hard. And I think we've discussed flagging some of these types of trade-off challenges for potential future public engagement models where we have members of the public wrestling with these things alongside us and giving us more specific feedback. So I would just say, minimizing financial hardship for individuals and families is one of our values that the keeping this in place supports, but we also have, we can't have community ownership without having a system that is simple and universally understood. And I think that is the trade-off that we're struggling with. So I will be supporting this motion. But I just want to cite that we have two values in tension, and that's what's making it really hard, I think, at least for me.
Any other discussion? Okay, should we vote? And the motion is to remove the household size rate readjustment.
Helen Blanca,
Be at the end. Abstain.
I'll say yes.
Chun-Wei Chi,
No.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez,
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
No,
Thank you, everyone. That's 6 yes and 2 no.
Isabel, I'm gonna encourage you to go non-alphabetically sometime.
All right. Did you have something else you wanted to say?
No, it's a question about Medicare.
Okay, yep, so we're going next. I know, thank you, everyone. Congratulations. Stay buckled in. So we're going to talk about Medicare Part B premium tax credit. So now, this argument, I would just say, or the discussion has two components to it. It is not whether or not there should be so much a premium tax credit, but really the two discussion points are, would you keep the premium tax credit as it is, or would the Medicare Part B premiums be paid outright? So those are the sort of the choices. So the arguments in favor of covering the premiums for all Medicare eligible people, as Chair Blanca mentioned, there's a couple of challenges. If a universal health plan is available, people may simply not pay their Part B premiums, which would result in a loss of federal funds coming to the state. Some individuals could potentially make enough money to be required to pay Part B premiums, but would not make enough to get 100% of the tax credit, as it's non-refundable. So in other words, people would still be paying their Part B premiums. Some parts of the argument have been given that it's not equitable to have the Medicare eligible population pay premiums at all, as no other population in the state is paying premiums. And another argument in favor of paying the premiums is that that would ensure that the federal matching funds will come into the plan, and it will also reduce the complexity of the plan. So it could make things simpler. Arguments against paying premiums, and the argument in favor instead of keeping it as a tax credit. Substantially were that if it were paid via the public corporation, if all Medicare Part B premiums, that would increase the total healthcare expenditure by an estimated $1 billion annually. So essentially that was the argument. And then if we go on to the next slide. Thank you. Again, at the Finance and Revenue Committee meeting, There was a motion to remove the Part B premium tax credit and replace it with paying all Medicare Part B premiums. It was a lively discussion. That motion failed, however, it failed essentially because it was a tie. So 3 no, 3 yes, and 1 person abstained. And so again, a potential motion, which is similar to what was put forth at the Finance and Revenue Committee, with to revise the revenue strategy so that the Universal Health Plan covers all Medicare Part B premiums, and the 100% Medicare Part B premium tax credit would be removed as it is no longer necessary. However, I want to be clear that in this board motion is simply that how the revenue strategy rates may be adjusted is still to be determined. So to keep that in mind. So it doesn't necessarily mean it would only come out of the healthcare personal income tax rate. So that's a potential motion, and turn it back to the chair. Or Judy, actually.
Yes,
Judy Richardson.
I have a question and a comment. So is the assumption being necessarily that a Medicare waiver would require enrollment in Medicare and payment of premiums? Because I'm thinking if I'm 68 years old and I have Medicare, why would I even enroll in Medicare? Well, because the UHP is going to require that counting, so we get federal funding. You just answered my question, but there's not such thing as a Medicare waiver, so do we necessarily know that they will be required to function just like they are? as
That's an
currently
excellent point.
existing?
I believe that you are correct in stating that is the assumption, that if the system
Okay.
were to be the way it is now and to get those federal funds.
Thank you.
Yeah, so that's a great point.
My only comment is I'm going to be for favoring the tax credit as opposed to payment, because every time money changes hands, it will add cost, administrative cost to the system. And complexity.
And it looks like Michelle has her hand up.
My question is, so we have one side of the equation, we have the cost of covering the premiums directly. So 1 billion annually, right? But do we know what is on the line in terms of lost federal match dollars if we structure it as a credit? So it's like a known cost versus an unknown loss? Is that
I
what
think
we're?
it's gonna depend on how many people pay it, right? So if somehow you had 100% of people paying their Medicare Part B premiums, you wouldn't lose any money. But really? You just get that?
No, that you would just get it back. That's what you're
Yeah,
saying.
just get back. Yeah. Right, but the UHP wouldn't lose any money.
Right.
The UHP wouldn't lose any money at all if everybody who was supposed to pay their premium paid it. I think what we don't know is, would people opt not to pay it? They don't have to pay it, right? In terms of like, that premium covers your ambulatory services, and they're gonna get all their ambulatory care through the UHP. And so if they chose not to pay their Medicare Part B premiums, they would save that money and still be able to get all the ambulatory care they needed. To me, if I was, 74 years old on a fixed income and knew that I could get any ambulatory care I needed without paying that premium, I think I would pay it. Right? There's no direct advantage to them to pay it. The advantage accrues to the UHP if they pay it, because we'll get, like $8,000 for every $2,400 they pay. Right? So the advantage is to the UHP. So that's a pretty tough argument to make. So we're just depending on people, like the honor system, I guess, we're depending on people paying it for the good of the community. And I'm not sure what proportion of the Medicare folks would choose to do that or choose not to, I don't know. So that's how much money we would lose. We would lose for every person that chooses not to pay it, at least 3.5 times that amount we would lose in the UHP. It's not a 1-to-1. The feds pay a lot more for Medicare Part B than if they get in premiums. And so we lose 3 times the amount for every person who chooses not to pay it.
So how do we get 100%?
Well, it's been proposed, I think that, if we kept it the way it is, it's been proposed that somehow you would require that. That if you're required to enroll in Medicare and you're required to pay your Part B premiums. I just, based on the experience of the ACA and, and like how every little piece of this could be litigated, right? And so we could pass a UHP and then that part of it wouldn't get passed. You would have to require people to pay it somehow, and then that part could be disputed. I don't know.
Well, in addition, if they're paying their taxes and they're trying to claim the tax credit, but they didn't pay their premium, then they are signing a fraudulent income tax.
Right. Right, but they could just not claim the credit too,
Right, fair.
you know, right? Go ahead, Marianne.
I guess the current way it's proposed would benefit higher income earners. Because they file taxes and lower income social security folks, may not be actually filing tax and able to get the credit. So I kind of think it's again an equity issue that I'm more in favor of paying the premium. I think that it's more fair and equitable. And makes sense with the 3-to-1 return, all of those kinds of pieces. And yes, I think that when this came up, it was kind of the last thing at the Finance and Revenue Committee. And we were already kind of going, oh my gosh, we're up at this 10% tax rate and we need another $1 billion. But I think we haven't, really come to look at what are those savings and is it really, are there other places that we can save that billion? So I'm in favor of the premium for those reasons of paying the premiums, as well as the only thing that would keep somebody from potentially, if we didn't do that, we just did the credit thing, from just opting out, is that they plan to leave the state. Because if you stop your Part B and then you need to start it back up again, there's a big penalty.
Right, so the portion of folks eligible for Medicare who plan to leave the state, they would be motivated to pay it.
Right.
But if you didn't plan to leave the
Right,
state,
and most
there
people
really is no
don't plan.
motivation. Right, and most people don't. Yeah, go ahead, John.
I have a clarifying question also related to comment. What happened for Medicaid beneficiary who, because of the income level, doesn't have to pay the household healthcare income tax because they're under 20%, but still have to pay Part B?
Yes.
And then they don't get a refund because they don't get.
That was Mary Lou's point.
I
Yeah.
think that's what I was trying to say.
Yeah, exactly. You're right, exactly right. So it disproportionately benefits higher income Medicare eligible folks and disadvantages lower income folks because they don't pay the tax, so they can't get the credit.
Yeah.
That's right. Yes, sure.
What about Charlie's comment? Is he suggesting we change some wording in the board motion? I just want to understand it.
What?
Maybe you understand.
On the screen.
Like rather than paying the Part B premium, it would be a refundable tax credit, so that would really change the motion, wouldn't it? I'm not sure I understand.
I'm not sure I understand either, but I think he's saying that, the plan paying the Part B premium would not have to be devised in that manner. It could be simply a refundable tax credit. I think
But that's the opposite of the board motion, isn't it?
right.
Yeah, the original
It's the
one was
opposite.
non.
It's still, I think what he's saying is it's non-refundable, so I think that would get at the lower income folks, that it's refundable if you pay it. But it still doesn't address the idea that people still may just choose not to pay it. But if you were lower income and, weren't eligible for the credit, you could make it refundable for lower income people, I think he's saying. But I'm not totally certain. Okay. Does anybody want to propose a motion? There's a potential board motion on the screen. You can adjust that, change it, propose something different. But some potential wording is up there.
I'll make the motion to revise the revenue strategy so that the universal health plan covers all Medicare Part B premiums and remove the tax credit.
Second.
Any discussion? Okay, let's do a roll call vote.
I'll go in reverse order. Mike Leahy.
Yes.
Mary Lou Henrich.
Yes.
Cheryl Ramirez.
Yes.
Judy Richardson.
No.
Bruce Goldberg is on leave. Michelle Glass.
Yes.
Amy Fellows. Yes. Chun-Wei Chi.
Yes.
Helen Belanca.
Yes.
Thank you, everyone. That's, I can't count, 7-1.
Okay, excellent. Thank you. Well done. Okay. Just checking the time. We need one final motion. If anyone, we don't have to do this motion, but if anybody is interested in proposing a motion that we approve the revenue strategy as outlined by both Morgan and Mimi earlier, with the changes that we are removing the HSRR and covering all the Medicare Part B premiums and therefore removing the Part B credit.
So moved.
Is that our second? Amy seconded. Michelle, you have your hand raised. Did you have discussion comments or were you seconding?
Had discussion comments.
Okay, go ahead.
I have I'm supportive of moving forward with a vote on the revenue elements as changed in today's meeting, but I do have a motion that I wrote during our discussion last month. So I will be a no on this vote because I have a motion that I'm going to put into the chat for consideration instead that just adds some clarifying language that I thought was really important about being honest about the work completed to date and that we acknowledge that there's need to identify analyses that remain necessary for a legally complete and implementable plan. So I think that would be helpful to add to this motion, just so it's really clear in the record what we are and are not saying with this motion.
Chenwei?
Again, this is for clarifications. With this motion, does that include the outline here in terms of the, for example, the proposed household income tax?
The HCPA?
Yeah.
Yes.
Because we just voted down for the HSRR. That means it's no longer 10.1%, it should be 11.06%. We should correct that.
Oh, this isn't the numbers. This is truly is just the
Structure.
That was
the
my
structure.
question.
Oh, that's a good point, though. That's a very good point. So yes, so
Just the instrument itself.
the instrument itself.
Not including the number.
Mhm. Right,
That's
and
a
so I believe the current motion on the table would be to approve the revenue strategy structure without the percentages. With the exception that we're removing the HSRR and covering all Medicare Part B premiums and therefore removing the Part B tax credit. Again, we're approving the structure, not the percentages. That's the motion on the table. And there will be a different motion with some clarifying language. It's been moved and seconded. Is there any other discussion, Mike? Oh,
It's just another clarification piece, so. I'll just say my thought, although I'm thinking that maybe my thing doesn't have to be included, and that is, what if we make other changes to this structure? Example, let's say, we've gotten a lot of feedback about there are clear advocates for 200% exempt, and there are people saying, no, you should be doing 38%. That'll change some of the calculations. I'm just trying to think through it. By us voting for this, we're not prohibiting any other changes in progress.
so we would be approving the structure, including that
We got
200%.
Which we already.
I wonder if we're not ready for this motion yet. I wonder if we need to sort of work out like how the numbers will change with the changes we made today and consider an alternative that doesn't include the 200%.
So just go with what the two motions that have been
Yeah,
covered. Perfect.
yeah. I feel like that's a valid point, Mike, and we need to think through like the implications of the two decisions we made today, how that'll change the other numbers in the strategy, and then look again at what the options are. So yeah, let's take a pause there. Thank you. Yeah, better not to rush through that.
I'd like to raise up that last one, that Oregon lodging tax, as part of this. I still think that I'm not really comfortable with that. You know, we said, oh, it would help with maybe the, to save for the administration of people from out of the state and what is that? And I just have been through lodging tax fights way a long time ago, and I'm just not sure that at this point in time that I'd like to cement it in there. And I'd like to have, maybe some more thought or a discussion about that.
Okay, so Michelle, I see your proposed motion in the chat. I think we're gonna take this up in our June meeting, and Mary Lou, I'd ask you to kind of put together some language
Yeah.
about, what,
Lodging,
about the
whatever.
lodging tax, get that to Mimi. We'll make some other considerations about how this will change.
And I'm just gonna add to like Mary Lou's lodging tax consideration, given fuel prices and like people are gonna be traveling more in state instead of going out of state because of the raising, you know what I mean? So like, we'll be charging Oregonians again. We might be charging people coming out of state, but like, when you don't live in the Portland bubble, like people travel
Right, within the state.
within the state,
Right.
and then we'll be charged the lodging tax, unless there's some kind of out for people with an Oregon driver's license or something.
So I believe technically we need to withdraw the motion. Who proposed the motion?
I did, I'm willing to withdraw and table the motion for future discussion.
Okay, the motion's been tabled. Great. And I want to check in with Lee. Do you want to do like 10 minutes on the implementation sequencing, or do you want to save for next?
I would rather save, it's a meaty topic.
It's meaty.
I
Yeah,
don't
yeah.
think a short bit is gonna do justice.
Right, okay. Okay, thank you for being flexible about that. So we have sort of considerations on like the HCPIT amount, the 200% of the FPL amount, and then the lodging tax to reconsider in our revenue strategy and bring back some ideas, examples, scenarios to formalize that for our next meeting. Right? Okay, any other items on the revenue strategy then, if we have another minute? Okay, should we look at the final report outline and review process? Yes, that will be Lee.
Alright, we can jump right in. This is nice and short. So just so folks know, this is our current final report outline. I know there's been a lot of concern about getting things done, but I just want you all to know that these kind of sections, especially the ones that have the sub bullets, have a fair amount of text in them. So like, we're doing well. I am not at all concerned about this being done by September. At least not with regards to the writing of it. There may be some content sections that look a little thin, but we knew that this was never going to be a final plan. This is a next step plan. And we're well positioned for that. So just to note, these little donuts, the ones that have the little green circle around them, those are substantially finished. There are a couple little orange bits in there that are going to, require some decisions that are yet to come. Obviously, board vote, we're not going to know that until end of the summer. But proposed model, which is really what does this look like from sort of the consumer side of things. That's mostly there, except for the interactions with other coverage, which our transition committee is going to be talking about in their next meeting. So that should come before the board very soon as well. And that administrative structure as well. Those couple topics also in line for transition committee. But those sections are nearly finished. So that first draft of this report will pretty much have those three sections in their entirety. Those that are in the orange or yellow, depending on how you read color, have a pretty solid framework to them. But they will not be provided in kind of a first draft. We'll discuss sort of the process of getting drafts out to folks, just because it's still in a really iterative stage. Obviously, we spent quite a bit of today's meeting talking about financing architecture. So that's something that, we don't want to provide you with that draft until this board has really locked down what it's doing, and we can be sure that what we're providing reflects a more or less final decision that we want to go before the legislature. We do have a couple key sections that we need to get to, that implementation pathway. So that'll be hopefully a big topic in June. Some sections on kind of risks and trade-offs. So
discussing, you know, some of the choices that were made and why they were made, as well as, of course, the risk of not doing anything. Because it is important that this work continues. And then when I'm calling a legislative playbook in there as well, which is really for the legislators to know this is what we need to happen next. So this report may look a little bit different, a little bit leaner than, like, say, what we saw from the task force. The reason for that is because a lot of this background material, such as, you know, the history of universal healthcare and, you know, why healthcare is so costly and everything, is moved to the appendix. The goal of this report is to be very action forward. What is the plan? What does it look like? What do we need from you, the legislators? So we will continue to provide you with updates as to what this looks like, and I'm happy to take any feedback that folks have regarding the structure of the report, the major sections, subsections, etc. I think we can go to the next slide, which is just our process. So as I mentioned, there is a draft that is pretty hefty right now. 38 pages is the one that I have, and that's not including any appendices. So that alone probably adds 100 pages even just right now. Thanks to our wonderful work of our consultants. So we will start releasing those at some point very soon with new drafts every 2 to 3 weeks. So there will be new sections that are coming out. We are requesting email comments on substantive issues. So really looking for, where does this not seem to align with the board decisions, board conversations, and where does something seem out of step? Please absolutely raise those to us. Those flagged subsections where there appears to be some substantive disagreement, we will bring before the board as sort of a package just to quickly say, you know, is this off? Is there, you know, a way that this needs to be reframed, etc. So we are asking that you commit to reviewing and providing comments between meetings. This is not something that we want to be going line by line in the meeting. So that's why we're asking for those substantive issues. Send those to us between meetings. That way we can have everything compiled and just kind of, you know, punch list through that. Any questions?
Can you go back to the previous slide? I was trying to think, the part that Michelle and I will be having heavy input in, the community engagement or community input, as it's written here. And so I'm trying to just in my mind, think about the busy legislators reading this and the structure. And so there's part that's like, this is what this board has done in this time. This is, you know, the decisions we've made. And then there's the part on like, you know, like we didn't have a budget to do true community engagement. We have recommendations on what that next phase looks like and kind of like, where does that fit?
Yeah, I think that next bit absolutely fits under the legislative playbook in terms of.
That's where that's at. Okay, got it. Just want to make sure.
Just to be very clear, to your point, we couldn't get all of it done. This was never meant to be like the perfect final plan, but here are the next things.
Okay, got it. Thanks. I just want to make sure I knew where that fit.
Yep, absolutely. Great question.
And then on the next slide, I just want to underscore for board members that if you see something in the draft that you disagree with and you provide that feedback to staff, please do, first of all. But that doesn't mean that that change is automatically going to get made. If it's substantive and it's sort of some disagreement about it, that's the decision. Those are the kinds of things we're going to bring back for board meetings. We're going to say there's disagreement about where we landed on this issue and let's talk about it. So, and we all have the chance to give that input. And when we seem like we disagree, we're going to have to work those out in the meetings. But to the extent that we can, we're going to provide feedback in writing to Lee so that she can update those between meetings and we don't spend too much time during the meetings.
One process question about that. So when we do that, then, because I don't want to get in trouble again, is I can't blind copy that to anybody else.
Oh, gosh, no.
Okay, just to the staff.
Right.
Okay,
Yeah, that's a really good point. Thank you.
okay, number one.
So yeah, we can't have any deliberations among board members outside of a public meeting. So, when you get sent the draft, you're sending it directly back to Lee. You're not sending it to other board members.
Okay. That was number one.
Yeah.
The second one is, I guess I just, whatever we put the title, I guess I don't want the word final. Because it seems to me that we're saying this isn't really final kind of, so I don't know, it just.
What are you referring to?
On her slide. Back, or next one, or however, I mean.
Oh, I think we were just
Oh,
trying to
final
be clear about what
report.
report we were talking
Okay,
about.
Yeah.
final report.
Oh, I see.
Okay, I just,
Yeah, I don't.
But I love workshopping names.
Legislative report.
Yeah, let's call it legislative report.
thank you.
Mike, did you have something?
Yeah, just a comment. I really like the outline. I think it's really good, and having been a part of many other reports, I've been thinking about it. It's really, it meets all of my pesky little questions, so I appreciate it.
Yeah, I'll extend on behalf of the whole board, thank you, Lee, for all the work you've already put into it and all the work that lies ahead on this. We really appreciate your organization and commitment to action-oriented report, which I think is all of our priority. Yeah. Any other thoughts, questions on the final report? Sorry, the legislative report. I just got that.
Thank you.
The legislative report.
Thank you.
Okay. Great. As always, we're gonna take a moment here to say, are there any topics, questions that you need to have answered in terms of updates or educational topics for our next meeting? So agenda items that you want to see on at our next meeting. This is the chance to make it known. Yes, go ahead, John.
I mentioned this before, but it seems we haven't got to that. Two helpful information for this board. One is, how is our neighbor Washington is doing in terms of their progress towards universal health care? That would be very helpful to us to know, and some information we might be able to share.
Okay.
The other is, we can get the reference. Again, our further up neighbor, BC, the British Columbia. Because Canadian universal healthcare is run by individual provinces. So it will be very helpful to get more information about how BC province is running their universal healthcare. So Washington State and BC.
Okay. Mike?
I brought this up before, but at some point, things are including. Judy mentioned something, I meant, there are things are changing in real time. And maybe the topic I'm suggesting is, are there other alternatives even before the UHPGB is clearly in place? For instance, as I was coming on, you guys did a report last year, interim report to the legislature. It's more of how do we respond to hospitals to the fact a lot of the CCO stuff isn't working, and yet it continues. That they're very only modest proposals right now to maybe tinker with some pharmaceutical stuff, but otherwise we're making believe the system is going to continue when I'm not sure that it is, and I'm very worried that there'll be more for-profit health plans and other things that we'll have to undo.
Yeah,
So maybe that is a topic.
that's great. We've called those stepping stones in the past.
Yes.
Things that we could do. So an update on stepping stones. We have a legislative session coming up. We've been talking to legislators. And so like a little update on what we think our current list of stepping stones is, things that we could do in the interim before UHP. That's great. Yes, thank you. We'll put that on. Anyone else?
I guess my question is when are we gonna go, or who's gonna go back and really try to take a look at what the actual expenditure number?
Oh, yes, thank you. I meant to do that at the end of that discussion. Right. Yeah,
Okay,
yes. Sorry, do you want to finish your question or you want me to just address it?
that's great, and then, I had something else, but it'll pop back.
Yeah, so, we have the Milliman report and their estimates of expenditures, and we have total confidence in the numbers that they came up with. We've heard some new information today, or not necessarily new information, but, sort of refined information about potential administrative savings. And we were originally going to do that today. I'm glad we took that out, but we did have another presentation today about what we could do in terms of adjusting the Milliman
Yes.
estimates in terms of fitting this discussion. We, not me, I'm gonna give credit to Mimi, predicted accurately that we'd run out of time before we got to that, and we really needed to get to the revenue strategy. And so we have delayed that till the June meeting. But the idea is, yes, we're gonna look at the Milliman numbers again, put them into context, show the savings that they've already accounted for, and then based on our number today that we came up with, which averaged to about 11% of administrative savings, see where that falls, and if we want to give LRO a different number, and that'll happen, yes, at the June meeting. But yes, I meant to mention that before, and I appreciate you reminding me. That's what'll happen with that. So we will consider Milliman's numbers in the context of what we heard today.
Okay.
Yes, I gotta put that on here because, yes, I don't think people got. Okay, anything else?
The only other thing that I have is that I think our minutes are amazing. They really detail stuff. But the thing that I have been in other processes where we've gone from something like that to more of a, like, who's responsible for X, Y, or Z. There are things that are in those minutes.
Action items.
Action items are the things that I'm not sure that everything that we said we were gonna do or whatever has been done. And so I don't know exactly how to be sure that there aren't little pieces that we said, oh, yeah, we're gonna do this or do that, and I don't know that we have done that, and it's a huge effort to kind of claim that out, but I'm just a little nervous that maybe there are some things that somebody brought up and we were gonna do it, and maybe it's something that I said I was gonna do and I didn't do it.
I think in the process of writing the report, we're gonna be needing to refer back to a lot of minutes, right? I'm guessing like there's a lot of decisions that were made along the way
Yeah.
and understanding the rationale, and especially if there's disagreement about what it said in our legislative report. So then we will be reviewing all those minutes, I think, as part of that
Okay.
report writing, and then we can sort of call out any action items that we didn't get to, or that, you know, we can decide if that's something we want to take on or incorporate. Yeah.
And there is a way, like, in doing the minutes, maybe folding things that are action items, putting on action items at the end. Sorry, my project manager, just turned on.
Okay, great. I think that covers it. We have a few minutes for public comment. And one moment. I believe we have 1, 2, 3, 4, 5, 6, 7, 8 people signed up for public comment. Is anyone in the room signed up for general public comment?
I'm not, I'm here.
Oh, there you are. Do you want to start? Mike? Or do you want to? Okay, go ahead, you can start.
Chair Belanca and board members, hard to believe this committee was bumped. This is a more important meeting, like, group I can think of.
Okay, our room.
We second that.
First comments are on what Dr. John Santa has sent you in writing and what he likely would have said had he been able to be here. Second is comment on Dr. Richardson's concern about provider and hospital reimbursement. Third is, can we nurture provider support for the universal health plan? First, as we just heard from Dr. Shao, the critical policy choice is whether to copy legacy insurer structures or single payer authority. To simplify administration through transparent rules, cooperative provider relationships, and streamlined processes. Doing so would free resources to improve access, benefits, and care delivery, and to address tax pressures. And it would signal that the Universal Health Plan is committed to shifting funds from administrative conflict to patient care. To that end, Dr. Santa suggests, and I agree, and it sounds like the board is planning to do create a full multi-year startup financial plan, develop alternative administrative models that explicitly capture single payer efficiencies, and hold a public vote on payer administrative expense strategies. The second, on Dr. Richardson's comment to providers, it seems likely that even though the provider quote reimbursement would go down, the net income would stay stable or improve following administrative and other savings.
The third is how can we assess, nurture, and provider support for the key elements of a universal health plan, such as statewide formulary? Do we have useful information for our focus sessions on provider acceptance of some of those major factors? Oh, I'm through.
Thank you, Mike. And as always, we encourage you, if you have more detailed comments, to submit them in writing. Thank you. So next is Stephanie Santos, and then on deck will be Kel Fox.
I don't see Stephanie or Kel online, unless they're in the room today.
Stephanie, Kel? Okay, then Lisa Caparello Snyder, and then Brianna Love-Wasson on deck.
Lisa and Brianna, I'm also not seeing online.
Okay, then moving on, David Call.
David's not online either.
Tom Sinsick.
Tom, we do have Tom there, so give us 1 second, Tom. And you should be able to share your comment now.
Tom, President of Nurses and Friends for Single Payer, you again for work our discussions that you've had. Happy to be here. Yes.
Oh, sorry, you were just cutting out for a minute there. Go ahead.
Am I good again? Okay. This is necessary to achieve. As you know, I have a constitutional amendment, just a ongoing reminder that we have this constitutional amendment and that the challenges must be met. There are many challenges mentioned, right? But you can't keep bringing those challenges up over and over and over again because it's not helpful. It's helpful just to focus on the product, to meet the ORS 751 statute as the major goal and make sure those board recommendations are aligned with that statute and the constitutional amendment, because that's the important work that you are all doing. It is the most important work going on in this state right now. One of those challenges, just a comment, is that this public corporation is not meant to run the organization, it's to oversee. So the message is about contractors. There are systems in place for claims making. There's the Epic system. There's the new Oregon Exchange. There are systems that can be utilized. This does not necessarily have to be a complete new startup. So with that in mind, we haven't considered the savings when we shift to public health and primary care. I do not think that's been brought up when we go upstream and take care of problems the way we should. Let's see. So I think that's kind of it. The hospitals, you know, they have big billing systems. That's why they're costing so much. They're not breaking any money. They're negotiating with the insurance companies. So we can fix the issue with the hospitals and the payment. Note that the advocates are already diligently at work talking to CCOs, businesses, and other people, also talking to legislatures. Deliver the product, and the advocates will deliver the result with the voters when it comes to the vote of the people. So thank you very much.
Thanks, Tom. And then Alex Polikoff.
1 moment. Okay, Alex, you should be able to share your comment now.
Can you hear me?
Yes.
Great. Thanks for your work as usual. And just quickly, I mean, you've heard my comments before, but you know, the system is broken. Our healthcare financing system is broken. It's only getting worse. So it's really important that the work proceed. So even though, you know, I've had some issues with some of the board policies, you know, just not to be a broken record, but an 11% additional personal income tax is just not going to fly with the legislature or the voters. So, but I'm not going to belabor that. I mean, it's really important the work go forward. So I'm just going to say, please finish the work. You know, Michelle put in chat, you know, a kind of a stipulation that went to be included with the report, that there are things that need to happen once the report is submitted, but give the legislators something to work with. They're going to slice and dice it. Just make it at least somewhat digestible so that it's not shot down right from the get-go. Like I mentioned, something, you know, that I understand that the effective tax rate is going to be a lot less like what Helen said, but it's that number that is going to be indigestible. So please do something about that, but please, please finish the work and allow some form of legislation to at least start in this next session, because even 2032 is going to be too late for a lot of people. So again, thank you for your work, and carry on.
Thank you, Alex. I believe that's everyone. Is that everyone? Is it on?
That's my list.
Okay, great. Do we have a reflection?
We do.
Oh, I've been watching the really quick spread of the Ebola epidemic, Africa. And it made me think of this book I read by John Green. I think it's called Everything is Tuberculosis.
Yeah.
Oh, yeah.
And that made an impression on me. And he made the case that TB is curable and preventable, which I'm sure you all know that. So I just thought this was a good brief quote. So I think this could solve a lot of our problems. We can do and be so much for each other, but only when we see one another in our full humanity.
Beautiful.
Thank you, Cheryl. That's great. And thank you to all of you for your work today. And we will see you in June. Thank you. We're adjourned. 1 minute.